तो दिया मैंने ये बैटरी वो ड्रेन होती है वाटर।
हॅलो.
बोला सर.
हा सर, आवाज येतोय बरोबर?
हो हो हो.
ओके.
बाकी तर लोक 4 वाजता जॉईन होतील, आपणच हे 3:30
हा
ला
हा
आपण टाकू.
4 o'clock.
हम्म.
हॅलो.
हा बोल.
नाही नाही, हॅलो, एनीवन इज फ्रॉम ILBS? राहुल, डॉक्टर राहुल?
23 जन ज्वाइन हो चुके हैं पर
हॅलो.
बराबर नहीं आ रहा है। अभी तो बिल्कुल ही नहीं आ रहा है। देखना बराबर नहीं आ रहा है। ब्राइटनेस बराबर नहीं, लाइट पीछे ज्यादा है।
सर मुख्यावर सर मागणं खूप लाईट येतोय तुमच्या.
हो तेच पाहतोय मी. ते आता मी नवीन ठिकाणी बसलो आहे ना, हॉस्पिटलमध्ये बसलो आहे. एक काम कर, पीछे का बैकग्राउंड निकाल ले. पीछे का बैकग्राउंड कौन सा है?
आता आलं.
संजय,
हा सर.
आता दिसतंय का बरोबर?
हो 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 सर, समोरचा अजून लाईट असेल तर थोडासा लावून घ्या, थोडा अंधार येतोय चेहऱ्यावर.
फोकस नहीं है.
गुड आफ्टरनून सर, मुख्यार सर.
हाँ गुड आफ्टरनून, गुड आफ्टरनून. कोण सचिन बोलतोय का?
हो हो.
अच्छा
सर गुड आफ्टरनून सुषमा.
हा काय म्हणते?
बस ठीक सर. आता दिसतोय सर, चेहरा दिसतोय व्यवस्थित.
दिसतोय ना? थोडं पाहतो मी, अजून एक फोकस लॅम्प लावता येईल. ते घरी सगळी अरेंजमेंट आहे पण.
हा तुम्ही क्लिनिकला असल्यामुळे तसं.
हो मी क्लिनिकला आहे. ते खाली चेंबर मध्ये खूपच गडबड राहते ना.
हो सर.
ओपीडी चालू असेल ना सरांची आता, पीक अवर्स.
त्यांना काम करत आहे.
हॅलो. Hello.
Hello there. How are you?
Hello.
Dr. Sushma, it's very nice to see you finally virtually.
Yes.
Good to meet you this way.
Same here, Dr.
Hello,
Nandita.
Dr. Shrikant.
Yeah. Hi.
Nice to see you.
Yeah.
And we have So welcome to ILBS, sir and ma'am.
Thank you.
We will be beginning sharp at 4. We just wanted to do a brief check.
Yeah.
So have that confusion sorted regarding the registrations participants are able to log in. Have you checked with some of the participants?
I think that Dr. Sachin will answer this question. Sachin? Sachin?
35 participants already joined. Rest they will join at 4 o'clock.
Correct. So there is, we have also shared a direct link. So in case if they are having any problems, there are two alternatives. There is direct link and there is also a web ID along with the passcode. So both of them are working. We have tested them both at our end. So they have two alternatives. Howsoever they feel is working, they can just go ahead and join in that way. And we begin sharp at 4.
Okay.
Can you tell me the sequence of lectures and who's supposed to deliver it? Hello?
Before I take you through this, before I take you through the sequence, could I just request a confirmation regarding Dr. Sudhir Gupta? Has he confirmed if he will be joining or not?
No, he's not.
He has not confirmed because he is having
He has
some
not yet.
important meeting with the minister today. So he said, I will try, but I don't think he will be able to join.
Okay. So here's the thing. What I'd suggest is we will be mentioning Dr. Sudhir Gupta, one of the chairperson, right at the outset of the webinar when the other chairpersons are getting introduced. And then whenever the session begins, so this is how we planned Dr. Shrikant. I'll be beginning with the welcome address. Just a welcome note opening the webinar formally. But before that, there'll be a pre-webinar link that will be shared for all the participants to take a brief survey before the webinar begins. That would be, the link would be shared chat box and there's a QR code that will be displayed on the screen. They can just scan the QR code and that will take them to the questionnaire. Once that survey has begun, it takes about 4 minutes for them to complete it. Meanwhile, we'll play some documentaries. Then we flow into the formal beginning of the webinar. The webinar opens with a brief about ILBS, about the project Empathy. And none of the speakers, panelists, nobody is introduced, but just the theme of the webinar is introduced. After the theme, then I open the floor to Dr. Sushma. Dr. Sushma takes over and then she delivers a welcome and objectives of the webinar. Dr. Sushma then hands it, she invites to Dr. Sachin Deotaye.
Sanjay.
Dr. Sanjay Deotaye, I'm sorry. So the keynote address, ma'am, you would be inviting Dr. Deotaye for the keynote. After the keynote ends, the floor passes back to me. And that is when I introduce all the 3 chairpersons, just a brief mention. After that, I take the viewers through Dr. Mukevar's profile. I invite him to be the chairperson and chair the 2 sessions that follow. The 2 sessions that would be following after Dr. Mukevar would be Dr. Ekta is going to deliver her lecture first. There's a slight change in the agenda. Kindly modify your agenda. Right after the chairperson address at 4:10 p.m., the first speaker of the day would be Dr. Ekta Gupta. She'd be talking on National Viral Hepatitis Control Program. After Dr. Ekta, we have Dr. Manya. And Dr. Shrikant, I request you to introduce both the speakers. I hope you have the PPT. In case if you don't, then I will display the profile on the screen.
Yeah, that would be better.
Okay.
But I have the introduction.
Okay. So Dr. Mukevar, you'd be introducing.
First lecture. So let me confirm. The first lecture is National Viral Hepatitis Control Program.
Correct.
By Dr. Ekta Gupta.
Sir. Right, sir.
Professor of Virology, ILBS. Okay. The second lecture will be Burden of HBV and HCV in India by Dr. Manya Prasad.
Correct.
Okay.
Sir. Right, sir. And then you would be passing the floor to me back again. And that is when I invite the second chairperson for the following sessions. That would be Dr. Abhiram Pranjape. So Dr. Abhiram Paranjape is introduced, invited, and then he invites Dr. Ajit Bhadoria and then Dr. Archana Ramalingam.
Okay.
After which, then Dr. Paranjape can pass the floor back to me. In case by that time Dr. Sudhir is coming or not, we'll have more clarity. For now, I'm considering that he won't be attending, perhaps, right?
Yeah,
and then we'll
yeah.
have a brief. Okay, we'll have a brief I pledge ceremony in which we'll be taking the oath. The oath will be displayed on the screen. So we request everybody, all the panelists, especially to turn on their cameras. The videos would be it would be displayed on the tray, and that is when we'll take the oath. The oath will also be displayed on the screen, so you just have to repeat after Dr. Rahul, who would be administering the oath. After that oath ceremony, the floor opens for plenary discussion. All the question and answers would be taken up then. So the chairpersons of the session would be requested to moderate that question and answer sessions. So after the question and answer session concludes, we'd see how much time we have for the question and answer, and then we'll moderate accordingly. Post which we'll have the conclusion by you, madam, and then vote of thanks by Dr. Sachin, and that is when the webinar concludes with a post-webinar survey, which will be displayed on the screen back again as the one we did it as pre-webinar. That is how it is. We kept it very brief.
Yeah, thank you, Dr. Mamata, for explaining very nicely. Thank you.
Most welcome. So we'll wait for another 15 minutes, and that is when we can have a live stream. So this webinar is also going to be streamed live on YouTube. And I believe Dr. Sachin required that link, so we'll share that link with him.
Dr. Sareen is going to join.
So it's Dr. Sareen's OPD day today, but he'll try to connect if there is a possibility, he'll try to connect of the sessions, if at all.
Okay.
But we can't be sure. We can't be sure about it.
मॅडम कॉलेजला आहे की घरी आहे?
सर घरी आहे.
लवकर सुट्टी आहे?
नाही सर, ते थोडं कालपासून टेम्परेचर येऊन राहिलंय. स्वॅब दिलाय तर घरीच थांबली आहे.
अब द्यायची गरज नाही आहे. पॉझिटिव्ह आज समजून सुट्टी करा.
हो सर, आज मी घरीच राहिली. काल अचानक संध्याकाळपासून 101 टेम्परेचर, कफ, बॉडी एक, सडनली सगळं सुरू झालं.
आहे.
हॉस्पिटलमध्ये खूप जणांना आहे ना, त्याच्यामुळे
वेबिनार अटेंड करा, वेबिनार करा.
मी सकाळी केलं होतं सचिनला इन्फॉर्म, पण मी त्याला म्हटलं मी जॉईन करीन म्हटलं, तसे काय, पण इन केस अगदी नाही सुटू शकली तर मग तुला इन्फॉर्म करते. परांजपे सर नाही झाले वाटतं मी जॉईन.
हो, अभिरामला फोन करून दे ना संजय.
हो सर,
तेच सांगणार होतो आता, अभिरामला फोन करून दे.
requesting your attention, Dr. Mukherjee, just a kind request. Sir, you would be chairing the session for Dr. Ekta and Dr. Manya Prasad. Just a slight modification. Dr. Ekta's session would be followed by question and answer straight away. Like her session's questions would be followed right after she stops talking. So you just have to moderate the questions directed regarding NBHCP after her session. Because she has some... Yes, okay. National Viral Hepatitis Control Program. Just relevant to the topic, all the questions will be taken shortly after her presentation itself.
Okay. Okay.
All right. Thank you so much. Rest of them remain the same. Question and answer at the end. Thank you, sir.
सर ते जॉइन करतात ते परंतु सर
Kind attention to all the participants. Kindly bear with us before we formally begin the webinar. We do have a pre-webinar survey that we'd like you all to take. Kindly go through the link. Click the link that has been posted on the chat box that you see right now. And also alternatively, you can scan the QR code that is being displayed on your screen right now. This will lead you to a brief questionnaire. You just have to answer those question and answer. It might be an exercise of just a couple of minutes. So we'd be appreciating if you could just kindly take this survey. There'll be a post-webinar survey as well after the conclusion of the webinar. We request you all to take both surveys in order to be eligible to download your e-certificates. Thank you. A very warm good evening to all our distinguished panelists, guests, speakers, and the participants connected to us for the national webinar on recent advances in prevention and control of hepatitis B and C, jointly organized by Indian Medical Association Nagpur and the Institute of Liver and Biliary Sciences, New Delhi. The Institute of Liver and Biliary Sciences is a deemed to be university under the UGC and has been established by the Government of National Capital Territory of Delhi. LBS is an international center of excellence dedicated for diagnosis, management, and advanced training and research in the field of liver and biliary diseases. While hepatitis B and C are the most common cause of deaths, with about 1.4 million lives lost each other. Amid the COVID-19 pandemic, viral hepatitis continues to claim thousands of lives every day. This is quite unfortunate because a very potent and a low-cost vaccine for HBV and a curative treatment for HCV is widely available. To address the concern, Government of India has recently launched the National Viral Hepatitis Control Program, we abbreviate it to NVHCP, with its nationwide implementation in progress. Both these topics about the HCV vaccine and the burden of hepatitis B and C in India, along with the National Viral Hepatitis Control Program, would be touched upon by the speakers that follow in the sessions to come. With this situational awareness, the Institute of Liver and Biliary Sciences conceptualized the Empathy Campaign, empowering people against hepatitis, with a funding support from Airport Authority of India. Under its corporate social responsibility, the Empathy Campaign is an attempt to spread awareness about hepatitis B and C, thereby the mantra of talk, test, and treat, besides addressing the stigma associated with the infection. In continuing our efforts to empower people against hepatitis B and C and tackling the challenge that is glaring and confronting us these days, we have the series of webinars, and today the host for the day is Indian Medical Association Nagpur that we are so proud to associate with. I welcome the distinguished guest and the host for the day, IMA Nagpur. Just to take the participants through the flow of the webinar, we'd be touching upon the crucial topics and the aspects of tackling this menace of hepatitis. We'll begin with a talk on National Viral Hepatitis Control Program by one of the integral technical resource person who was part of developing the national program, followed by the burden of hepatitis B and C in India. And then the webinar flows to discussing the transmission and prevention of HBV and HCV at community level. We'll be concluding the sessions with the screening and vaccination strategy being discussed, along with the health education for HBV and HCV at community level. The webinar concludes with a beautiful ceremony that we call the I Pledge Oath Ceremony, in which we insist all the participants and the patrons and anybody with a keen interest of taking and being the flag bearer of our fight against hepatitis to take the oath to educate, disseminate, and be aware of hepatitis. An honorary mention to the man, the visionary behind the empathy campaign, and the efforts in the direction of dealing with the menace of hepatitis, which is also included as one of the sustainable development goals, that is to eliminate hepatitis B and C from the country by 2030. Professor Kumar Sareen, he is the vision behind the spirit that drives all of us at ILBS. Professor Sareen is the Senior Professor Hepatology and the Vice Chancellor of Institute of Liver and Biliary Sciences, New Delhi. He was instrumental in setting up the Institute of the Liver and Biliary Sciences under the auspices of Government of Delhi. He is also the Director, WHO Collaborative Center on Chronic Liver Diseases and Viral Hepatitis at ILBS. He continues to serve as adjunct faculty, molecular medicine at JNU due to his deep interest contributions to the translational science. And I now extend my warm welcome on behalf of the team Empathy and ILBS to the Indian Medical Association, Nagpur, to kindly please take over the webinar and formally begin. May I, Dr. Sushma Thakare, IMA AMS Chairperson, Convener of IMA Nagpur, and Associate Professor, Community Medicine, IGGMC Nagpur. She's also the executive member of IAPSMM and has published about 50 research in various national and international journals. Madam continues to be a guide to more than postgraduate students. A very warm welcome to you, ma'am, and I hand the forum over to you.
Okay, thank you so much, Namrata, and good evening to all. So with the behalf of Indian Medical Association Nagpur, I welcome you all for national webinar. Indian Medical Association Nagpur, in association with Institute of Liver and Biliary Sciences, New Delhi, organized a CME on recent advances in prevention and control of hepatitis B and hepatitis C. With these few words, I welcome Professor Kumar Sareen, sir. I also welcome our President of IMA Nagpur, Dr. Sanjay Devtare, Honorary Secretary, Dr. Sachin Gathe, all the office bearer of IMA Nagpur, MMC Observer, Dr. Dinesh Agrawal, today's chairperson, respected Dr. Shrikant Mukewar, sir, and Dr. Abhiram Paranjpe, sir. Today's eminent speaker, Dr. Maya Prasad, Dr. Ajit Singh, Dr. Archana Ramalingam, Dr. Ekta Gupta, Dr. Namrata Mohan, all the panelists, moderator, MOC, and participants. With this few words, we all are aware that despite the high global burden of disease due to chronic hepatitis B and C infection and the advances and opportunities for the treatment, most people infected with HBV and or HCV, and they remain unaware of their infection, therefore frequently present with the advanced disease. So early identification of the infection would enable infected person to receive the necessary care and treatment to prevent or delay the onset of liver disease. And in addition, it prevents the transmission by HBV vaccination of the non-immune household contacts and sex contacts. We all know that in spite of effective vaccine available against the hepatitis B, but only because of the lack of awareness among the high-risk population, many people suffer from serious liver disorders. So I think the main objective of this webinar is to create awareness first among our doctor fraternity regarding the recent advances on prevention and control of hepatitis B and C. So thank you very much for giving me opportunity to speak. And now I invite our President of IMA Nagpur, Dr. Sanjay Devtare, sir, for his keynote address.
Thank you very much, madam. Good afternoon, respected dignitaries, speakers, chairpersons, and a wonderful audience. More than 200 people they have joined. On behalf of IIM Nagpur, I welcome you for the CME, Recent Advances in Prevention and Control of Hepatitis B and C, which is a major causative agent for hepatocellular carcinoma, and this can be very easily preventable. Today is a World Cancer Day, and the theme for this year is Close the Care Gap. I also welcome Dr. Dinesh Agrawal sir, MMC Observer. Big congratulations to Dr. Sushma Thakre madam, convener, and Dr. Sachin Gathe for taking lots of pain for organizing this CME. I especially thanks Institute of Liver and Biliary Science, New Delhi for joining hands with the IIMA for this noble cause. Jai Hind, Jai IIMA Nagpur. Over to you, Sushma madam.
Yes, thank you so much, sir. So with this, I request the Dr. Namrata again to continue.
Thank you so much for a very beautiful welcome and explaining the objectives of the webinar and the dignitaries that are associated with us today. May I kindly invite the chairpersons of the sessions that would be now following, Dr. Srikant Mukhewar, Dr. Sudhir Gupta, Dr. Abhiram Pranjape. To begin with, may I kindly invite Dr. Srikant Mukhewar, DM Gastroenterology, Postgraduate Institute of Medical Education and Research, Chandigarh, is where he got his degree from. And also Dr. Mukhewar has been practicing gastroenterology in Central India for over 35 years. Currently the director and the head of Midas Multispeciality Hospital Private Limited, which he established in January 2002. Midas was set up as a comprehensive care center with the philosophy of offering complete gastrointestinal care at an affordable cost. The comprehensive care includes, apart from the routine GI endoscopies, facilities for all kinds of gastrointestinal surgeries, radiology, and a well-equipped intensive care unit, the first of its kind in Central India. Over the past 10 years, Midas has established itself as the leading gastrointestinal care center in the region. Dr. Mukhewar earned his MBBS and MD degrees from Nagpur University. He completed his super specialization from the prestigious PhD IMER Chandigarh. I extend my warm welcome to you, sir, and may I request you now to open the sessions.
Thank you for that kind introduction. Good evening, everyone. At the outset, let me express my sincere thanks to IIM Nagpur and ILBS for giving this opportunity to chair this important scientific session. First of all, let me compliment Dr. Sareen and his entire team of ILBS for the wonderful work they are doing in the field of hepatology and biliary sciences. They are revolutionary in doing the research work, education, and the patient care. So it has been one of the prime institutes doing a great job for Indian people. Today's topic is more relevant because hepatitis B accounts for 1/3 of hepatitis. 50% of the chronic liver disease is secondary to hepatitis B and C, and about 2/3 of liver cancers are attributed to hepatitis B and C. It is relevant that this disease should be definitely prevented. So today's topic of recent advances in prevention and control of hepatitis B and C is a very relevant topic. May I have a pleasure in inviting Dr. Ekta Gupta to introduce the first lecture of the symposium, National Viral Hepatitis Control Program. Dr. Ekta Gupta works as a professor and head of clinical virology, ILBS New Delhi. She's done her MBBS from Kanpur and MD microbiology from King George Medical College, Lucknow. She has received the Best Scientific Award Gold Medal for outstanding work in clinical research by ICMR. She is a technical resource person for developing National Viral Hepatitis Control Program in India. She has several extramural research grants, both of international and national faculties, course faculty for WHOCC at the Institute, has more than 80 scientific publications, published in journals and books. Her major research interest is viral hepatitis, transplant viruses, and other viruses. With this brief introduction, let me have a pleasure of introducing Dr. Ekta. Over to you, Dr. Ekta, for further proceedings.
Good afternoon, everyone. Can you hear me?
Yeah. Please go ahead.
Okay. So, good afternoon and very warm welcome on behalf of Institute of Liver and Biliary Sciences to IMA Indore, and thank you for your kind words, Chairperson, sir. And without wasting much of the time, I would like to start sharing my screen. Can you see the screen now?
Yeah.
And hear me? Okay. So I bring to you greetings from Institute of Liver and Biliary Sciences, and I am Dr. Ekta Gupta. I head Department of Virology. I am also the nodal officer for WHO Collaborative Center at Viral Hepatitis Program, which is running in the country right now. And so the top is very apt, and sorry that I had to prepone it because of certain other academic commitments. So I'm going to speak on the National Viral Hepatitis Control Program in India. Now, there'll be lectures on the burden of BNC and why the country came up with this program, but briefly touching upon that globally, it was realized, as you can see in this cartoon, that it is not HIV, malaria, or tuberculosis, but the problem of chronic hepatitis B and C as a silent disease and as a sequelae complications is rising and causing a lot of morbidity and mortality. So this was in the Global Health Sector Strategy when the report came out in 2017. Whenever the decisions have to be taken globally, I think it is the global health sector and WHO which comes out with what needs to be done. So they had set certain targets for each country, and they said that if this problem is going to rise, we really have to do at each government and each country level certain efforts. They set up two important targets for B and C. One was that in 2030, we must reduce at least the new cases of hepatitis B and C by 90%, deaths which are attributable to B and C by 65%. So this was decided in a global health sector meeting, which was conveyed, and so the government of India also became signatory to this. But before that, and so they set up certain interventions and indicators. So I think subsequent speakers are going to tell you more about how to do screening and whom to screen, but I'll just touch upon what were the targets which were set. So the main focus of each country, what WHO and Global Health Sector Strategy told each country is that see where your lacunae is there globally and where you need to pump up your efforts. So in hepatitis B vaccination, although they were quite a good effort which was shown globally, but still you have to bring it higher. Mother to child, prevention of mother to child transmission of hepatitis B is a very, very important component, and administration of birth dose within 12 hours after birth was need to be. So each government was told that you need to intensify your effort, because as in my subsequent slides, I'll be telling you what is the problem of hepatitis B from mother to child transmission and why this is a very important intervention which needs to be adhered to. So see, baseline data just showed 39% and it needs to be increased very high. In terms of blood safety, globally, the countries were doing very well because of the HIV program already in existence. So you just need to keep it up with the same speed. What was lacking drastically was this hepatitis B and C diagnosis. You can see the percentage which were being given this diagnosis. And so if this is such a less percent and bringing this target to 90, so this requires a lot of effort by microbiologists across the countries, by physicians, internal medicine people, and the gastroenterologists. So you can see there was a major gap, and these are a lot of publications which has come up globally. WHO themselves have published a very good paper in Lancet Gastroenterology where they have shown across the countries, if you see the number of positive hepatitis B, actually surface antigen positive patients and anti-HCV, but those who are offered and diagnosed and offered treatment is so less. So this gap is a huge gap, and where we need to focus is on this diagnosis part. So in India, we know there are, everybody knows there are 5 viruses, A, B, C, D, and E. A and E, and it's easy to remember from the fingers of your hand. A and E are hyperendemic. So all waterborne, acute onset viral hepatitis, whether pediatric associated, adult associated, is mostly by A and E. And A and E, although there are reports from Western world of the chronic hepatitis C, but it is, we have done a lot of huge studies, especially in the transplant areas. We have not found E as a chronic infection still now, so we call it a hyperendemic and normal jaundice. This program is, these components are also included, but the focus of the program is more on B and C, which you can see is a huge problem. So we have data about B, 40 million infected, 12 million by C, but you know, the actual coordinated effort in a well-documented approach was lacking, and that is why we came up. And ILBS at the national level had a lot of role. I must thank Professor Sareen, who were the guiding force to all of us. And I was very fortunate to be a part of all these as a nodal officer in viral hepatitis who was involved. So we, what we did was from 2014 itself, when we came to know the WHO targets, we started doing these annual meetings. We called Government of India, we called WHO, and we were there. And then we had every 28th of July, which is the World Hepatitis Day, we had these 1 to 4 consecutive meetings, and these are our draft of meetings. They are all available. Finally, in the year 2018, when Shri J.P. Nadda ji was the health minister, we persuaded the government to launch National Viral Hepatitis Control Program. It was launched first in 2018, and all these PDF documents are available. It is through the Government of India and NCDC, that is National Control for Disease Control Organization, is the main key player. So all these PDFs are available. Anybody who wants to access these documents, wants to understand, I'll be briefly touching upon them, but the detail can be seen and we can provide you. And thankfully, I am the resource person for most of these guidelines. So we know how we are heading. Although this program was launched in 2018, but because of the national COVID outbreak, you all know, all microbiologists got involved in that. Somehow it took a backseat, but again, we are pushing the states towards moving towards this program. So the aims of this programs are very, very clear. Ours is the only country which focuses not only on C, but B and A and E. So we are going to target hepatitis C elimination by 2030 by rapid diagnosis, finding out maximum patients in any viremic, offer them treatment, which is an all-oral 12-week treatment, and clearing. And this virus can be cleared. We know that this virus does not bind to the liver, is not lifelong inside the patient, so you can clear. Second, efforts will go on reducing the morbidity and mortality by B, more by B and as well as by C. And you can do, again, identify more and more those who require treatment, put them on treatment, keep checking their liver health and follow them up so that the morbidity and further mortality is reduced. A and E, we are going to just do screening, but yes, any outbreaks if they are occurring, any focal points if they're there, we will offer services to control them and also link them to Swachh Bharat and safe, hygienic and toilet practices so that these outbreaks and safe water and drinking water supply is maintained and sanitation services in India. Now, how this program is organogram, I know it's slightly complicated, but I'll make it very simple. Just like the National AIDS Control Program, it's slightly it will be run by the center from the National Health, under the National Health Mission, where the Chief Secretary or Additional Secretary Health is the chairman of this program. But it is not going to be like NACO that every procurement, all centers, they belong to them. They're going to handhold the state, and each state will be controlled through the state health mission, just like the National Health Mission. They will provide budgets to the state. Each state has to identify where to make model treatment center, where to make a state national diagnostic state lab for viral hepatitis, and then the budget provision will be provided. So unlike NACO, where the staff, everything was provided by them, here it will be a fund support, and we will do already existing institutes and government run institutes in hand-holding. Another flexibility this program gives is to involve private labs. So if you do not have a good state lab where these testing of viral load can be done, because idea is that you should have a good turnaround time for the reports. They should be available and patients should be put on treatment. You can also partner with a private lab and a budget will be provided at the cost which is decided by the national program. Then all the treatment, dispensement of drug, all this will go down to the district and the sub-district. So the medical officers who are there sitting in dispensaries, these primary health centers, they all will be capacitated if your state involves you in one of those, and then the treatment can be given, the medicines can be given to you, the rapid diagnostic cards can be provided to you, and you can actually do a diagnosis, put the patient on treatment and do a follow-up. So this program, we are going to depend for B and C, basically the screening of B and C based on the serological test. And the test we are going to use mostly is the rapid diagnostic test. The testing can be done by the ELISA and other chemiluminescence level, but here, because so that maximum testing can be given to maximum patient at a very cheap cost. So we are going to depend upon rapid diagnostic test. They have a good specificity of 100%, although the sensitivity is slightly low, but nevertheless, they are a good source by which you can do very rapid diagnosis. Confirmation of all those who are positive in the initial screening will be done by molecular test, that is the PCR test, RT-PCR test. And these services will be either at the district hospital if they already have. Mind you, in this program, we are not giving a provision for buying the equipment. Rather, we will support already existing equipment site with reagents and consumables. So the confirmation will be through the PCR. Treatment of uncomplicated cases means if the patient is non-cirrhotic, there is no other comorbidity. In that case, can be done up to the level of the primary health center, while the complicated cases will be taken care at the model treatment centers. So this program is going to run through, as I have shown you, the district level health centers, the model treatment centers, the diagnostic lab centers, and then there is at the center of excellence. We are going, as I told you, we will depend more on the rapid diagnostics. So just for those who don't know what a rapid, these are the simple card tests, which work on the basis of lateral flow assay or flow through assay, where a drop of direct blood prick input, and basically HbSAg and antibody to HCV. These will be the two card tests which will be provided. If you are at a district then level lab, then reagents for ELISA or a chemiluminescence, if you already have these instruments, can be provided to you for confirmation or in certain complicated cases. Molecular test will be only simple viral load test, which will be real-time PCR-based assays, which will be there at the level of your model treatment center or at the medical college, wherever a sophisticated lab for doing these tests is available. Genotyping will be only available at the state level viral lab because it is not needed. It is, I'll tell you, it will be needed only in the complicated cases where certain drug decisions need to be taken or drug resistance testing needs to be done. So basically, there will be at the primary health center level, the provision of availability of rapid diagnostic card test for B and C. At the district hospital level, if you have ELISA chemiluminescence, then the reagents can be given to you. And if you have RT-PCR machines, then you can do RT-PCR testing. At the state level lab, everything will be available so that any discordance, anything, if the lower level labs need, they should be able to give them correct results, and they should be connected and doing a hand holding for their capacity building. At the center of excellence, which is will be at only one at the national level, there the provision of sequencing will be made available so that in case of difficult to treat or decisions needs to be taken for drug resistance or genotyping can be made available. Regarding the treatment algorithm in this, at the sub-district levels, there will be wherever you have medical officers, you will be a drug dispensing site and follow-up of patients. So the drugs in their particular dosage can be procured by you and you can actually enroll patients. I'll show you how the guidelines and how you can enroll them. At the district hospitals level, you should be capable to, we will make a center, a treatment center, only if you are capable of taking care of all uncomplicated cases, and a referral mechanism is available where you're attached to a tertiary level lab where all complicated cases. So in a complicated cases, we assume that there should be a good radiology setup, there should be a gastroenterology or endoscopy services available, and then they should be able to refer them to, in case if a transplant needed, to a transplant center. So this is how the hierarchy of testing and treatment is proposed in this. So each state can make their own algorithm, and these all information is given under the national guidelines, where to make what. Now, what are the important challenges we are anticipating? Although now these guidelines are laid down, we are giving a lot of information to state. We are telling people that come forward, state that come forward. There is a budget provision available. Identify your sites where you're going to do these things. The problem is that the linkage and continuity. Because one, to make a state viral hepatitis control unit who's going to take care of all those who are enrolled in the state, and so that at least in hepatitis B, the follow-up where you're going to give lifelong, so the continuity of care and treatment and follow-up of these patients is done. So this is where we anticipate that the problem might come. Another problem is that you can offer a large amount of serological testing by RDTs at the primary health, but labs where a confirmation of a piece by a PCR has to be done so that the patient is not lost and he gets its report and is put on treatment might be there. There can be a drop off. And so you require more and more of microbiology lab setup with the PCR and ability to diagnose hepatitis B and C viral loads. Communication of results, so you have to have an HIS or an information system so that a patient is not traveling to and fro between two sites for getting a report. I think the COVID pandemic has done, this is a silver lining of this cloud, that they have set up this method of transport of samples, result communication, and PCR capability to most of the microbiology. So one can piggyback on these setup under this program. The other important thing is that you must identify a place in your state where the complicated cases can be managed so that anybody who comes into this program is taken care of till the end, till the complication is there. Now, I'll be briefly touching upon the guidelines which are there because the time given to me is very short, so I'll be hurriedly touching upon them. We all know hepatitis B virus is a DNA virus, and it has, there are very important antigens and proteins, but two very most important antigen is, one is the hepatitis B surface antigen, which tells you about infection and ongoing infection also, and confirmation of the eligibility for treatment is dependent upon the HBV DNA. Rest all markers can be done in individual patient-to-patient management, but in this program, we only focus on HbSAg and HBV DNA, not the other markers. Briefly touching about this, most of you know, and it is an old diagram, why I said that the one important intervention, that is giving birth dose vaccination at 12 hours to all pregnant, all those who are newborns, is very, very important, because you know that most of the chronic hepatitis B infection is acquired in the childhood. So more than, if you acquire from mother to child hepatitis B virus, 95% chances that you will land up into chronicity. These are the stages of chronic infection. Now we no longer use the word inactive carrier, and this thing we use word like hepatitis and infection, E antigen positive infection, E antigen negative infection, E antigen positive hepatitis, and E antigen negative. This is a new terminology as per ASLD guidelines, but I have used this whole diagram just to show that 95% of this chronic infection is coming from mother to child. So one intervention at institutional deliveries, giving birth dose vaccination to 100% of those who are born in the institute, will break this chain of transmission, and finally we'll be able to curtail this menace of hepatitis B in our country. Very less people who acquire a new infection in the adulthood will land up into this. The body is able to clear the virus, and it is only the mother to child transmission will land up into the chronicity. So in hepatitis B virus, acute infection, if the body is able to clear the surface antigen, the DNA on its own, nothing needs to be done. Yes, in less than 1% cases, the patient might land up into the acute liver failure, where you need to have arrangements for such a case. Otherwise, it is the management of chronic hepatitis B with this algorithm. These are the WHO guidelines, and the national guidelines are also dependent on it. So we are going to depend for the diagnosis of hepatitis B by simply doing a hepatitis B surface antigen card test. If the patient is positive, then you're just going to see how is the liver health. Patients cirrhotic, non-cirrhotic. If the patient is cirrhotic, there is no need for a DNA. You have to give the patient treatment, and it is the nucleoside analog therapy that you have to give, and then monitor the patient as per the guidelines. When the patient is on treatment, then 3 monthly you have to call to your treatment center for getting a DNA done, or sometimes anti-E can be used, but usually DNA and ALT is the one by which the monitoring is done. Now, in case the patient is surface antigen positive, is non-cirrhotic, then you go for two more important tests, that is ALT levels and the viral load, HBV DNA levels. If ALT is not persistently abnormal and DNA is whatever, you have to initiate the treatment. If ALT is normal and DNA is more than 20,000, then only the treatment needs to be initiated. So one has to stick to these guidelines in initiating hepatitis B treatment and management, and do a follow-up. Now, if your candidate is not put on treatment, you need to monitor for treatment at least annually. Keep calling the patient, get the ALT and DNA, so that you are keeping a check on the patient whether he is coming into this cascade of offering treatment or not. So that is why I said that most important component in hepatitis B management is going to be linkage and continuity. Because once you enroll a patient into your program, you are not going to leave him. You have to call the patient annually so that he requires treatment or not is cleared. What are the drugs which are available? They will be available free of cost. So you have both the combinations of tenofovir, TDF and TAF entecavir and for patients with compensated and decompensated doses. So these are the drugs which can be procured by your state and wherever is your treatment centers, and as per the guidelines, simple medical officers can also give the treatment. Now, this is a flow through. It's not that complicated, but once you become a model treatment center, the patient can just walk in. Even if he knows he has done a positive HbSAg, is already there from outside, he can still come, get an HbSAg done, get enrolled into the program. You give him the treatment card, and as per the guidelines, either by ultrasound or by an APRI score, or if you have fibroscan, you just assess whether the patient is cirrhotic, non-cirrhotic, offer him a treatment card if he requires treatment, and then you give drugs to him for 30 days and keep calling him and giving the treatment and follow up the patient for subsequent sequelae or other thing development. So it's very simple algorithm. Model treatment centers can also be can do, and even at the district hospitals, if there are medical officers, they can be trained and the treatment can be given to them. Only in complicated cases, you need to refer them to a gastroenterology setup in your state where the necessary provision should be made available, and then they are managed with the different drug combinations and regimes. Hepatitis C virus is a much simpler virus. We know it's an RNA virus, and there is only one test, that is antibody to HCV. And mind you that even if it is an antibody to HCV, it tells you about the exposure to infection. So it is not a protective antibody. Since you cannot do a core antigen, although now the assays are available by which you can actually detect core antigen, but they are limited available. So it is an antibody response to HCV, which tells you about the exposure. Confirmation of an ongoing infection needs to be done because in 20 to 30% cases, we know the HCV virus is cleared from the body on its own. So it's only 20 to 30%. So if your antibody to HCV comes out positive, only in 20 to 30% that the HCV RNA might not come positive, but in 70% cases, if you have an antibody positive, if the patient is not on any treatment, you will find an HCV RNA which confirms the ongoing infection. So the guidelines which are given for HCV management is very, very simple. Do an anti-HCV assay, confirm the infection by doing an RNA, any RNA, refer for treatment and treat the patient. What are the drugs which are available? So you have all these all oral direct antivirals. And now the things are very, very simpler. These are pan-genotypic regime. Do not need to do any genotype. Just see whether the patient is cirrhotic, non-cirrhotic, or decompensated, non-compensated, and then offer. So normally in the program, we give a combination of NS5B inhibitors. So in the hepatitis C virus, you have a 5B region and you have an NS5A region. And we have two-pronged approach to target the virus. We give drugs for the 5B region. Usually the drugs which target the 5B region, they start with the word Buvirs. So sofosbuvir is available, and asavirs are the drugs which target the 5A region of the virus. So declotasvir. So these are the drug regimes which are available. They will be available free of cost, and you can put the patient on treatment. Even ribavirin will be available for the complicated cases. So this algorithm is very clear. You only need to procure the drugs, put the patient on the cascade of treatment. You have to give a treatment for 12 weeks, and now you do not require any other lab monitoring. So put the patient on 12-week treatment, wait for 12 weeks after the completion, and then get a second RNA test done. So you just require 2 RNA tests, one before the treatment and next 12 weeks after 12 weeks of completion, that is SVR, Sustained Virological Response 12, which is tagged. If it is negative, give a certificate, you are free from hepatitis C. Now, this requires only this much follow-up. Unlike B, where annually follow-up even if on a treatment needs to be done. So hepatitis C is a much simpler, which can be given at a district level hospital or a sub-district level hospital. Genotyping is not recommended at all before the treatment, only in case you are decompensated, certain treatment combinations fail, then you need to type and understand the drug resistance workup. So the algorithm for hepatitis C is very, very simple. A patient comes, you do an anti-HCV, antibody positive, get a viral load tag, any viral load, give a treatment for 12 weeks and do an SVR at 12 week, SVR 12, to see for the clearance of the virus or not. Once cleared, hand over a certificate, you are free from hepatitis C. Hepatitis E and A, we only have included IgM provision in acute cases because we know that they both present as acute jaundice. And so whenever a patient presents with acute jaundice, it matches with the peak of IgM occurrence. So it is the IgM antibody to hepatitis E, which is very, very helpful. And so is A IgM, which is very, very helpful to make an etiology. So just for the sake of an etiology identification of acute hepatitis, we have kept HEV IgM assay and HAV IgM assay, which will be made available at the state viral lab in case the diagnostic algorithm needs to be completed. So this is a proposed diagnostic algorithm when a patient is having jaundice. So a jaundice patient, we feel that there is an acute occurrence also. So we will do A and E IgM. We will do B surface antigen. We can also do core IgM to hepatitis B to help us in understanding the acute etiology of B and C antibody. And then for B and C, the same way you have to refer, as I have described you earlier, the B and C guidelines. A and E, nothing needs to be done, but only for the etiology identification, we will do HEV and HAV IgM. If the patient is without jaundice, so only B and C, we will not do A, will not do E, will not do core IgM of B. So that these algorithms I have already explained to you all. So this is what B and C guidelines is and how this program is and what is the current status. Unfortunately, as I told you, COVID-19 pandemic took a toll on this. So we could open only 710 centers and more than 30 states have already participated. In Delhi, I'm also a part of the Delhi State Viral Hepatitis Program unit. So we are also still struggling with making these district sites and treatment centers and availing these treatments and establishing the linkage to care, but very soon we will come up. So this program has already been there. There is a linkage to other programs. For example, for hepatitis B vaccination, we are going to link to the already existing immunization program, and for healthcare workers, for at birth, but we are pushing more for institutional deliveries. So we are going to link with mother to child program also in this, under this. So I finally summarize that in order to meet the ambitious goal of 2030 for eradication of hepatitis C and reduction of mortality and morbidity by B and C, the government of India has launched this National Viral Hepatitis Control Program. What we need to do is enhance the diagnostics and uptake of testing, and it is for general population. So it is not, program is not for only high risk or those who require this thing. Anybody can walk into these centers and can get a testing of B and C done. Each state has to do an effort now to make a plan. As I've told you, they have to identify what are going to be, if your state has not made so far, then please, you can contact your state health mission or state health secretary or whosoever that we want this program, and they can identify what are the district hospitals, who is going to be a model treatment center, who is going to be a state lab for your district. And these diagnostics and drugs are all free of cost, which will be made available to them, just like COVID. And we want that more and more hepatitis B and C patients are put onto treatment so that we end this menace of viral hepatitis. So I thank you all.
Thank you, Ekta. It was a wonderful, wonderful comprehensive review of the National Viral Hepatitis Control Program. You went through all the detailed steps of diagnosis, management, and how to set the centers all over the country. And you emphasize that both these diseases are silent diseases and we need to improve our diagnostic testing. I am also of the opinion that as a clinician, I would also give a message to everyone that if you have liver enzyme elevation, if you want to do some procedures, get the hepatitis B and C. That is how we will be able to pick them up in the early stages before they get a diagnosis. Your point of improving a diagnosis at the early stage and is well taken. You all gone through the natural history and the treatment of these hepatitis B and hepatitis C, of course, with the advent of direct antiviral drugs. We assure that probably our aim of eradicating the virus by 2030 is probably in the pipeline. So I have a few questions to you. Do you feel that as the hepatitis C is likely to be eradicated by 2030? How about hepatitis B? What is your opinion on that?
Sir, hepatitis C is easy to eliminate because there is no association, because B, C and HIV, when we see, C does not go and bind to the host nucleic acid. It is, so C, if you just treat the patient by 12 week and show, but only problem in C which I'm enforcing is that if the C is because of IV drug users and other thing, then they get on getting the repeated reinfections. So a very good post-treatment counseling needs to be given, and patient needs to be told that, see, once we have treated you, now again do not come up with the new strain, because you will not be able to prevent the reinfection. So otherwise, if counseling is given properly and treatment is given properly, C, you're going to eliminate. B is a problem with the existing drugs because they target only DNA polymerase. You are not targeting the triple C DNA, which is there inside the liver. So, but if your B viral load is brought to a negligible level by giving an antiviral, and education is given to the patient for increasing his, taking care of his liver health, co-vaccinating for hepatitis A and other like flu virus and COVID, so that other insults to the liver are prevented. I think the morbidity and mortality by B can be brought down to a larger level.
B is still a significant problem, though we don't see many C as compared to B. E appears to be a major problem, at least in our part of the country. Sushma, are there any questions? Can you take up the questions in the chat box?
Yes, sir. There is one question in the chat box. So, shall I read, sir, that question?
Yeah, sure.
So this is for Dr. Ekta Gupta. That how is the follow-up program for metabolic patients on hepatitis?
Sushma, your voice is not clear. Can you speak little louder?
Yes, sir. Yes, sir. So how is the follow-up program for metabolic patients on hepatitis B virus treatment protocol to assess the adverse outcome cardiorenal?
Okay. The question is that what is the follow-up program for the metabolic assessment of adverse outcome of renal and other. So in hepatitis, in this national viral hepatitis program, we are going to monitor. So for C, once the treatment is given after 12 weeks and your SVR12 is viral load negative, you're just going to hand over. We are not going to do further follow-up. Though regular education and counseling for taking care of your health, other insults in the form of fatty liver, the problems associated with alcoholic fatty liver disease, non-alcoholic fatty liver disease will be explained. But in this program, there's no provision for kidney. Yes, definitely. Once you put the patient on these antivirals, there are certain which has a component on the kidney. So as a gastroenterology, but in complicated cases only, your renal checkup and other checkup will be done. In non-complicated cases, we do not anticipate much problem with these drugs. For B, you're going to do a lifelong monitoring. As I told you, there is no escape. You have to do an annual, you have to recall the patient and keep on advising on how to keep a liver health. So we are going to have a role of counselors in telling them exercises, diets, and vaccination for other viral infections, so that the liver insult is not there.
Ekta, you said that majority of the transmission of hepatitis B occurs horizontally in the early age group. What do you think is the commonest mode of transmission in hepatitis B, and that too also in hepatitis C?
So the commonest, I think the subsequent speakers, Archana is going to take this, but I'll tell you the commonest, what we have seen in hepatitis B in India is mother to child, that is the vertical transmission. Horizontal transmission has been reported, but it's very rare. In my career here in the Liver Institute for the past 15 years, I have yet to find an adult acquiring acute hepatitis B from needle stick injury or unsafe injection practices or through blood transfusion, because of the very good blood screening and other safe injection practices program. So mostly B, it is mother to child. For C, yes. And I still do not understand that why C is still associated with unsafe injection practices, because we did a nationwide survey through this program, and we found that most common cause of C was there when you are adhering to unsafe injection practices. So in IV drug users, dialysis, hemodialysis patients, and those who are using these razors and blades, not those practices, in them hepatitis C prevalence has been seen. So B is more mother to child and C is more unsafe injection practices in India.
There are some more questions.
Huh? Go ahead.
Yeah. Second question is what to do if second dose of hepatitis B vaccine is missed by a patient?
I think the subsequent lectures are there by Dr. Archana on vaccination.
Okay.
So she will be, I think, covering these issues. So I'm not going to touch on that, although I can answer, but let the speaker tell. Yeah.
Okay, no problem.
Should we go ahead with the next topic? Thank you, Ekta, for that wonderful lecture. And we'll be missing you in the panel discussion, which is going to follow at the end of this thing. But certainly, this was very educating and informative to all of us. I'm sure that the message would spread all over and it will help in preventing Hep B and Hep C throughout the country.
Yeah. Thank you, sir. Thank you.
Thank you, Ekta. With this, we go on to the second lecture, the burden of hepatitis B and C in India. And this will be by Dr. Manya Prasad. Dr. Manya is the Assistant Professor, Clinical Research and Epidemiology, ILBS Delhi. She has 35 national and international articles at such a young age. And her area of interest is epidemiology, medical research, systemic reviews and meta-analysis, evidence-based medicine. She has facilitated many workshops on research methodology, evidence-based medicine, and great tool. She's a gold medalist in MD final examination. She is a recipient of International Epidemiology Association Fellowship. With this kind introduction, I welcome Dr. Manya and give us an overview of Hep B and Hep C in India. Over to you, Manya. Please go ahead.
Thank you so much, sir. Grateful for that kind introduction. And I also extend my gratitude to IMA Nagpur for jointly organizing this webinar with ILBS. I'm so grateful to all of our esteemed colleagues that joined in today. In the interest of time, I think I'll just get started with my slides. And what I've been told to talk about is the burden of hepatitis B and C in India. So what I'll take you through is the reported estimates of the prevalence of chronic infection due to HBV and HCV in India. I will also do a critical review of the current literature. I think that's important in view of the limitations that are there in studies that are assessing the actual prevalence of HBV and HCV. I will provide some estimates from recent studies and again juxtapose them with the lactinates that are there. And I will also talk about the rate of liver complications. And I'll finish with some sepsis. So I think you're convinced by now that this is an important area to focus on. We need to think about hepatitis because it's the leading cause of mortality worldwide, one of the leading causes. And it's certainly a very important public health problem in Southeast Asia. It's one of the communicable diseases where mortality is actually increasing, or there's an indication that there's increasing mortality. And it's responsible for at least as many, if not more, deaths annually than TB, AIDS, or malaria. And around 90% of these are due to hepatitis B and C infections. We need to worry about this because this is actually something that's amenable to prevention and control. We have a very effective vaccine for hepatitis B. And also we have a cure for hepatitis C and very effective drugs that are not very expensive for hepatitis B. This is pertinent more so in the era of COVID-19. Of course, COVID-19 poses a major challenge in achieving hepatitis elimination, but it is documented that the interruption in services for elimination has been more severe for hepatitis than other diseases. So hepatitis elimination efforts have suffered more than HIV, malaria, or tuberculosis. So things like vaccination, screening, and health education have been severely interrupted, and it's something that we can't afford. So it's about time that we shift the focus back on this. Of course, when we talk about burden of hepatitis, what we're of course worried about, apart from the acute infection itself, is the very dangerous complications of cirrhosis and hepatocellular carcinoma. And so it's of course the prevalence, but then also the incidence of cirrhosis and liver complications due to cirrhosis and HCC. So coming on to the actual numbers, if we talk about worldwide prevalence, 296 million people are living with chronic hepatitis B and 68 million with chronic hepatitis C. The WHO estimate for 2015 was that viral hepatitis accounted for around 1.4 million deaths worldwide. And hepatitis B resulted in an estimated 850,000 deaths, mostly from cirrhosis and hepatocellular carcinoma. So you can tell that this is a huge problem globally. And in terms of 40% are estimated to develop serious sequelae during their lifetime, that's HCC and cirrhosis. These complications accounted, so cirrhosis accounted for 720,000 of these deaths, and HCC for 470,000 of the total deaths. So this is the spread of the prevalence across different WHO regions, and of course there's quite a lot of disparity in terms of the burden in actual numbers. So the total is 296 million, and the regions that are more severely affected are the Western Pacific and the African regions. So 116 million in West and Pacific alone. And then of course of India is a part of Southeast Asia region with 60 million cases of hepatitis B. And in terms of hepatitis C, again, there's disparity across regions. Southeast Asia region has 10 million cases of chronic hepatitis C. In terms of endemicity, India lies in the low endemicity region. The way that they plot this is by looking at prevalence of surface antigen. Estimated for India is less than or equal to 2% now, and I'll talk more about this in the subsequent slides. Within the Euro region, the countries have a gradient in terms of the prevalence. Of course, some countries suffering more burden, like Indonesia, Myanmar, Thailand. And this is true for both HBV and HPV. So again, we see some disparity here in terms of the countries. India, I'll just talk about various figures next. So finally, coming on to the prevalence of India, prevalence of chronic hepatitis B in India. And we get the estimates from 3 research groups primarily. And so the first is the paper by Schweitzer et al. The second is the WHO that engages independent agencies for estimation. And the third is the CDA Polaris group. Now, this is the comparison to the worldwide estimate. The estimate from India is in the second row here. So 1.46% is what is estimated from this paper that's purported to be the most reliable estimate. The estimate from WHO pretty close and with a very large overlap in the confidence interval also. And then the estimate from CDA Polaris is 2.5%. Again, a little higher, but again, in terms of the overlap in the confidence interval, there is quite an overlap. So those are the estimates for India from these 3 research groups. Now, just a word about what these research groups actually went about doing to arrive at that estimate. And all of them are systematic reviews and meta-analysis. They've all peer-reviewed published literature, but the WHO paper also had some unpublished data from member states. They've all summarized the data from about the same region, but certainly about the same timeline as each other. But what they differ in is sometimes some of the papers excluded high-risk groups and non-representative populations. That's true for the last 2 research groups. Whereas the included population was slightly different for Schweitzer et al. Also, the number of countries that are included in those thematic summaries are slightly different. So that can account for the variation in the pooled estimate. And so this is the paper that reports the estimate from 129 studies, and they included 3.7 million subjects. These were all studies, these were all primary studies, cross-sectional studies that were done across India. And what they estimated was that there are 17 million chronic carriers. In terms of the trend across different decades, they did a subgroup of the studies from 1957 to 89, and then a decade later, so 1990 to 2013. And we can see from this that the prevalence estimate has certainly reduced. So prevalence is reducing, as is indicated from the point estimates of these 2 periods, as well as the confidence intervals. And in terms of the WHO estimate, this is what the pre-vaccination 2019 estimate tells us, that there has been a reduction, and this can possibly be attributed to vaccination, of course. So 2.13 to 1.95. And then we have a slightly higher estimate from CDA Polaris, that's 2.5%. And they, of course, did a modeling exercise to arrive at this estimate. So these are the various recent studies that have been conducted across India. And we can tell from this that there is a lot of heterogeneity in terms of the population that they have enrolled in their studies. So some have included general population, some of them patients, and some of them blood donors or eye donors, which is possibly why there's a high discrepancy in the overall prevalence. There's also a lot of variation among studies in terms of the testing method. So again, that could possibly be one reason why there's a wide range in the prevalence reported. And so what can be observed here is that very robust data on the prevalence, on the countrywide prevalence of hepatitis B is still to be desired in terms of a nationally representative sero survey. So these were just the recent studies. And for HCV, prevalence of chronic HCV, what We have from one systematic review is again a range from that studies have reported estimates from 0.09 to 15%. But the estimate from community-based studies and those on blood donors and pregnant women is 0.85%. And what this paper estimated was that 6 to 12 million chronic HCV infected patients are there in India. And 3 to 9 million persons with active HCV infections. And chronic HCV accounts for 12 to 32% of HCC and about 20% of cirrhosis. So as you can tell, there are some limitations. The quality of the reporting is variable with high heterogeneity in terms of the kind of patients that are enrolled, or the testing method, and many other things in terms of methodology. And we also have a combination of robust and non-representative studies enrolling different age groups and different time points. There is paucity of data in terms of age-specific and sex-specific estimates. And we also have a healthy donor effect. So a lot of these studies were done in blood donors, which possibly could lead to an underestimate of the prevalence. And of course, most of the studies are at subnational levels, and some in very targeted high endemicity regions like tribal regions. In terms of mortality, what we can tell from this graph, the lightly shaded part is the mortality from hepatocellular carcinoma for HPV and HCV respectively, and the darkly shaded one is from cirrhosis. And we can tell from this that a large proportion of the mortality that's occurring in these diseases is due to these complications, cirrhosis and HCC. And then in terms of absolute numbers, we can tell that there's a high burden. 141,000 estimated deaths occurred due to liver cirrhosis due to hepatitis B. And the age standardized death rate for this is also rather overwhelming. That's 7.8 per 100,000. If we talk about rate of liver complications, this was a paper that was published in Gastroenterology that made conclusions from the global burden of disease study. Now, of course, let me state the most important caveat here first, which is that this relies on certification of death, which is rather very poor in India. And so we have to take that into account when we're making any conclusions from this data. But what is seen from at least the point estimate, this depicts the percentage change in liver complications due to HPV. So that's liver cirrhosis and HCC both combined. And so the percentage change globally from 2007 to 2017 is a reduction. At least the confidence interval, the point estimate shows a reduction. Whereas for India, it's actually an increase, 7% increase. But then the confidence interval is very imprecise. So this is not a reliable estimate. But again, if we look at the point estimate for death rate due to cirrhosis in HCC, due to HBV, again, for the global estimate, the point estimate at least depicts a reduction in death. However, for India, it shows a positive percentage change, so 2.15% increase. And this trend holds for both individual liver cancer, so that's 14.46 increase from the point estimate, as well as cirrhosis, so liver cirrhosis and cancer both. So finishing off, this is going to be talked about by Dr. Ajit as well. So I'll skip most of this just to say this, that this has prompted the WHO to implement the Global Health Sector Strategy, which aims for a 65% reduction in deaths from chronic HCV and HCV by 2030, and a 90% reduction in new cases. But ultimately, what is required is a public health approach, and we need all of these different interventions to be in place in order to be able to achieve those targets. And I think I'll finish here in the interest of time. Thank you very much for your attention.
Thank you, Manya, for that wonderful statistics which you showed. We also should share our data, which is not, unfortunately, not published, but we have had an opportunity to test hepatitis B in rural areas in the camps. and we have studied about 250 people there, asymptomatic, and none of 250, none was tested to be positive. And in our hospital area, those people, those who were coming as relatives of the patients when they were tested, out of 4,500 patients, 2% turn out to be Hep B positive. So earlier it was believed that it is 4%, 5%. Those were the statistics. But I personally feel that the prevalence is low in Indian subcontinent. There was a paper from Dr. Rakesh Agrawal regarding Hcb prevalence, which says that the prevalence of HCV in blood donors is 0.44%, while in pregnant women is 0.88%. However, there is no good community data in Indian subcontinent about the prevalence in general population, because there is reports from Punjab, West Bengal, where there is, and Maharashtra, there is a lot of disparity, very high prevalence in Punjab and very low prevalence in Maharashtra and West Bengal.
Absolutely, sir. Thank you so much for those insights, and very interesting to know the data that you just described from your hospital and your center, and must be published, I feel. It's absolutely correct. What I observed also is this, that there are some non-representative groups or some groups that have been taken as surrogates for general population. And being able to extrapolate that estimate for the whole community or the whole of India is rather difficult and maybe quite often far-fetched as well. So that's what the limitation is so far, which you very articulately put forth. Thank you so much.
You want to take questions now, or should be at the end of this symposium?
So we'll take all questions at the end now.
Because there is always an overlap of the questions in the same topic. Yes. I think Abhiram is here. Can I see Abhiram?
Hello.
Abhiram, are you there?
Can you hear me, sir?
Yeah. We can hear you. In fact, you can proceed with the next part of the project.
Yeah. We now proceed to the third lecture. The session is very interesting. And our speaker now is Dr. Ajit Singh Bhadoria. Ajit Singh is a MBBS from GRMC Gwalior, and he has done MD in Community Medicine from Jabalpur. He is working as epidemiologist at prestigious ILBS New Delhi, and he is a coordinator to WHO Collaborating Center on Viral Hepatitis. He has more than 100 research papers. He is a recipient of prestigious ICMR Professor Srivastava Award in 2016. He is a nodal officer of National Viral Hepatitis Program, also managing editor of Journal of Medical Evidence, and with WHO headquarters Global Hepatitis Team, is a member of the Guidance Development Group for Hepatitis C self-testing, and also SOP, and has developed SOP for enhanced reporting of acute hepatitis cases as scientific committee member from Southeast Asian region countries. So welcome, Dr. Ajit, and we are eager to hear from you.
Thank you so much, sir. Thank you for your kind introduction. So I'd like to mention here that I worked in ILBS for 5 years with Dr. Sareen, and whatever you've seen in that slide about my achievements, I'll say the credit goes to ILBS and to Dr. Sareen. I'm also very thankful to Umesh Kapil sir for providing me this opportunity to contribute in this very useful webinar, I'll say capacity building or knowledge dissemination webinar, because this is very important, especially for viral hepatitis. We want our doctors to know whom to screen, how to screen, whom to treat and how to treat, so that things becomes more easy for this program to become a successful program similar to other programs in the country. So for this session, I'll be talking about transmission of hepatitis B and hepatitis C. And this is very important to understand that hepatitis B and hepatitis C is very much similar to HIV. And in this session, we'll talk about what are the different modes of transmission for hepatitis B and C. Dr. Shrikant, he asked a few questions to Dr. Ekta also regarding the transmission. So I'll hope that after this session, the doubts will be more clear. And we'll also be talking about strategies for preventing the transmission. What are the general precautions? Vaccination is a very important strategy. I'll just touch briefly about vaccination in this session, then it will taken up again by Dr. Archana in the next session. Then post-exposure prophylaxis plays an important role for hepatitis B. So overall, we know that there are 5 viruses, A, B, C, D, E. A and E, they are fecal-oral transmission, and they are spread through contaminated food and contaminated water. And we hope that our Swachh Bharat Abhiyan, Swachh Bharat program can take care of these 2 viruses. Then for B, C, D, we are talking about B and C. We're not talking about D because D is, we can call it as a defective virus, which goes with hepatitis B as either a co-infection or as a super infection. So when we talk about parenteral transmission, it means that it is transmitted either through blood or blood products, or through sexual transmission, or perinatal transmission from mother to child, which is also known as vertical transmission, and sometimes inapparent horizontal transmission, which are in close contacts, household contacts, where there might be some sharing of razors, sharing of toothbrush or other things, which leads to horizontal transmission. So blood transfusion mainly due to unsafe transfusion of unsafe blood or unsafe blood products, which are not properly screened, or they are infected with hepatitis B, C, or other transfusion transmitted infections, and then they lead to transmission of infection. Nosocomial routes, which we should all also know about hepatitis B and C, which are similar to HIV, is through dialysis or through unsafe injections, needle stick injuries, which often goes unreported. And so this is important, that needle stick injury should be all reported and handled and managed properly. Then transmission is also documented through surgeries, dental procedures, organ transplantation, and other than this, sometimes also when there are practices of making tattoo, or there are practices of nose piercing or ear piercing, and that type also, if there is infection can occur through the people who are involved into these activities, and they're not knowing about such kind of infections can be transmitted. Sharing of needle among people who inject drug is an important mode of transmission for hepatitis B, hepatitis C, and also for HIV. So this should also be at least we should also try to stop this. We'll know about how we can stop this also. So that was overall. And if we talk specifically about hepatitis B, so I'll say most common mode of transmission is mother to child transmission, that is perinatal transmission. So if you'll have one patient, if you screen the siblings, if you screen the spouse, if you screen their children, if you screen parents, there are studies which has documented even 40 to 60% positivity rate among the family members for not only HBsAg but also for anti-HBC and other viral markers among family members. Other than perinatal transmission, horizontal transmission is also seen with hepatitis B, and healthcare associated, which we have already discussed, is also a common mode of transmission for hepatitis B, other than sexual transmission and transmission by sharing of needles. So most of the slides in slides, you'll see things there repeated. This slide is important to understand that if hepatitis B virus is transmitted early in the age, early in the life, then chances of converting that infection into chronic infection is very high. So if the transmission occurs at birth because of mother to child transmission, and then there are chances that that infection will convert into a chronic infection in 90% of the cases. So that's why we want to prevent mother to child transmission in hepatitis B. Right, so this graph, you can see if the infection occurs late in the life, then the chances of chronicity or converting into chronic infection goes down. So preventive strategy, most important is vaccination. So if we can have a 100% coverage of 3 doses of hepatitis B vaccine, if we can have a 100% coverage for hepatitis B birth dose, we can eliminate hepatitis B in future. So these two, this vaccination is very important strategy. This is mainly for infants, newborns, and then this is now included for healthcare workers also. So it's mandatory for all the institutes that they should get all healthcare workers vaccinated. High-risk groups should be identified and targeted for vaccination so that we can block transmission of hepatitis B in these high-risk groups also. Other than vaccination, the other strategies which are common for HIV and hepatitis C, they also play an important role in preventing hepatitis B infection. So how good is this hepatitis B vaccine? So it was introduced in Universal Immunization Program in India in 2007-2008. And if we give a single dose, the protection is 16 to 40%, 2 doses 80 to 95% protection, 3 doses 98 to 100% protection. A far better vaccine than COVID-19 vaccine, which we are giving to everybody with the efficacy of 70 to 80%. Right? So this is a very good vaccine and will help us, if we can improve the coverage to 100%, will help us in achieving the elimination targets for hepatitis B. I want everybody to know that hepatitis B vaccine may have some non-responders also. So in healthcare, if a healthcare workers or those who are involved in high-risk activities, they want to know whether they are protective or not, anti-HBs titer is a good method to know about the protective status of the individuals. So if anti-HBs titer is more than or equal to 10, then the person can feel safe or feel protective for hepatitis B. One important message which I want to give through this slide is that if any time in the life anti-HBs titer is more than 10, then there is no need to get this titer done again. There is no need for any booster. There is no need for any other vaccination approach if it's more than 10 anytime, even once in life. So the coverage of hepatitis B vaccine of 3-dose coverage is more than 80% in globally. Even in Southeast Asia region is also more than 80%. But the target which we want to achieve is that it should be more than 90%. Now, this is a very important graph which tells us about the impact of vaccine coverage on hepatitis B infection transmission. So you can see this thin black line is going down as the coverage of hepatitis B 3-dose vaccine or as the coverage of hepatitis B birth dose vaccine is increasing. So this gives us a clear evidence in favor of vaccine that if we can have good coverage of hepatitis B 3-dose vaccines and birth dose, it will pull down the hepatitis B transmission, it will pull down the new cases, it will pull down the incidence of hepatitis B globally. So why timely birth dose is important? So we have seen this in the first slide also, that chronicity is more if it is mother to child transmission, and if the infection occurs later in the life, the chronicity goes down. And we know that chronic hepatitis B leads to cirrhosis, leads to liver cancer, which are the major contributor to the mortality because of viral hepatitis. 96% of the mortality occurring because of viral hepatitis is due to either hepatitis B or hepatitis C. So if we can have hepatitis B birth dose timely, we can prevent chronic infection, we can prevent new infection of hepatitis B, we can also prevent deaths occurring due to hepatitis B complications or sequelae like cirrhosis and liver cancer. So what do I mean by timely birth dose? Timely birth dose means that first dose of hepatitis B vaccine should be given within 24 hours of birth to prevent mother to child transmission. And there are studies which showed that if birth dose followed by 2 doses of vaccine, hepatitis B vaccine is given, the efficacy is more than 90%. So more than 90% of mother to child transmission can be blocked only by vaccine. So if we see hepatitis B vaccine birth dose coverage, this is very poor. Globally, it is poor. If we see that like globally, it's only 38%. So the target is to increase it to 90%. Birth dose has its own limitation. It's not easy to give an intramuscular injection to a small newborn baby with little muscle on thigh. So sometimes A&M, they don't feel that confident. Even the family members, they are hesitant. So vaccine hesitancy is very common, plays a very common role in poor coverage of this birth dose. And even institutional delivery is also very important. We do not have, we still do not have 100% of institutional delivery. So why mother to child transmission is common in India? Why mother to child transmission is common in developing countries? This is multifactorial. Because of high birth rate, because of low institutional deliveries, because of poor antenatal care, because of poor birth hygiene in developing countries, because of poor coverage of hepatitis B birth dose as low as 38% globally, and also low HBsAg testing during ANC. So we know the reasons why mother to child transmission is common. So what could be the good preventive strategy? The best preventive strategy is that every pregnant female should be tested for hepatitis B. Every newborn should get a birth dose within 24 hours. And those with hepatitis B infected mothers, they should also get hepatitis B immunoglobulins within 48 hours of birth, so that we can prevent mother to child transmission and we can block the transmission. So that was about hepatitis B, which was mainly focused on mother to child transmission, vaccination, and birth dose. Now, if we talk about transmission routes for hepatitis C, they are also similar to hepatitis B and HIV. But if you'll say most common, I'll say most common is unsafe injection and unsafe blood. Among hemodialysis patients, among those who need multiple blood transfusions, they have hepatitis C prevalence as high as 30%, 40% prevalence is also documented in some studies among these groups. So unsafe injections and unsafe blood, they are the important carrier of hepatitis C infection. So if we can provide safe blood, if we can provide safe injections, we can block the transmission of hepatitis C. Sharing of syringes and needles among people who inject drugs or intravenous drug user is still a very important and good challenge. As mentioned by Dr. Shrikant, it's hepatitis C prevalence is more common in Punjab, because we know that intravenous drug use is common. Hepatitis C prevalence is more common in northeastern states in Manipur, because intravenous drug use is more common. They do not have that much of money. If they have money, they want to use that money to buy drug instead of going and buying syringes. So harm reduction approach by providing them sterile syringes and needles can help us in at least stopping this sharing of syringes and needles, and can block the transmission of hepatitis C among this special group. As mentioned earlier, tattoos, body piercing, they also can transmit hepatitis C when contaminated equipments are used. So training of these people, training of tribal groups who practice such activities can help us in preventing hepatitis C transmission in these groups. Unprotected sex, so safe sex, preventing mother to child transmission is not an important strategy for hepatitis C, but yes, it is also documented that even there is smaller amount of mother to child transmission for hepatitis C also, other than horizontal transmission, which can be by sharing razors, toothbrush among close contacts. So how to prevent hepatitis C? So to prevent hepatitis C, mainly safe injections, safe blood, harm reduction interventions by providing sterile needle, sterile syringes to people who inject drug, safe sex, occupational safety, like those who have needle stick injuries, they should be screened and then given post-exposure prophylaxis can play an important role in preventing hepatitis C transmission. So other than these routine, regular preventive strategies, I'll say if we do not have a vaccine for hepatitis C, test and treat policy can prevent transmission also. Why? Because we know that 95% of hepatitis C infected patients, they do not know their status. They are asymptomatic, they're living in the community and transmitting infection. So if we can start increasing testing uptake, and we can test them and we can identify those who are infected and then can treat them, could act as the most important strategy to prevent or to eliminate hepatitis C. Vaccination for hepatitis B, test and treat policy for hepatitis C can eliminate these two deadly diseases. Nosocomial infection, we know similar to HIV, hepatitis B and hepatitis C, they also can transmit nosocomial. So we need to have universal precautions. Hand hygiene, safe handling and disposal of sharps and biomedical waste management, safe cleaning of equipment, sterile equipments, screening of donated blood, improved access to safe blood, and training of health personnel. This is very important. This we do. All institutes, they have some training strategies, capacity building strategies, so that at least every healthcare worker will follow universal health precautions and can prevent and will not get himself a disease and will not transmit a disease to others. So prevention of hepatitis B, hepatitis C transmission in people who inject drug, I say, other than harm reduction, this third point I have already mentioned, other than harm reduction, we can also target this group for hepatitis B vaccination. If we can provide hepatitis B vaccination with some incentive, or then it can act as a very good strategy to prevent hepatitis B transmission. Other than opioid substitution therapy, this is important. If we can cure their opioid dependence, we can pull them out from this PWID group or pull them out from this IDU group, so that they are still in the same group where the transmission of hepatitis C is common, right? So because in hepatitis C, though we have good treatment available, though we can treat these people who inject drugs for hepatitis C, but the chances of reinfection is still there. So if those who are still involved in high risk groups, if we can treat them for opioid dependence, they can come out of this high risk groups and can be a part of general population. Sexual transmission, same guidelines, same suggestions as we know for HIV, correct and consistent condom use, testing of sex workers in high prevalence settings, eliminate discrimination, gender violence, more awareness, more education, so that they can come up for testing, they can avail the services. Not only medical services, but social services are also important for this particular vulnerable group. For post-exposure prophylaxis, there is a needle stick injury. So if a person is unvaccinated, we can give hepatitis B immunoglobulin, and then we can initiate hepatitis B vaccine series. If they are previously vaccinated, an antibody response, antibody titer, antibody to hepatitis B surface antigen titer is not known, then we can get them tested. If it is more than 10, no need for any treatment. If it is less than 10, then give immunoglobulin and one vaccine booster dose, because they are previously vaccinated. One vaccine booster dose is sufficient. This is my last slide. This is very important slide also, because it tells about global health sector strategy on viral hepatitis, what are the targets and what impact we are looking for. As it was shown by Dr. Manya, that our aim is to reduce mortality by 65%. Our aim is to reduce new infection by 90%, so that we can say that we have achieved elimination for viral hepatitis by 2030. So for incidence reduction to 90%, in this slide, impact, we want to reduce hepatitis B and hepatitis C incidence to less than 90% by 2030. What we need to do? We have to increase the coverage of 3 doses of hepatitis B vaccine. Currently, it's 87%. So we want it to be around 90% or more than 90%. So this is very much achievable, and maybe I think we'll achieve it by 2030 for sure. To prevent hepatitis B virus mother to child transmission, we have to increase the coverage of birth dose, which is very poor at present. It's only 34% in Southeast Asia region in 2015. So we want to increase it up to 90% to achieve this decrease in incidence as an impact. Then blood safety, safe blood, 100% safe blood. Unsafe injection should be dropped from 5.2% to 0%, maybe by using auto-disabled syringes or any other measures, so that we can prevent this unsafe injection practices in healthcare setting. And then harm reduction among people who inject drugs by providing them safe, sterile injection sets with needles and syringes. So it's only 29 sets are given to people who inject drug. We want to increase it to 300 injection sets per year to a person who inject drug, so that at least they can stop sharing needles and the transmission can be blocked. So these are the 5 important service coverages which we have to target, so that we can have this impact of reducing incidence of hepatitis B and hepatitis C by 90%. Just to summarize, hepatitis B and C both are parentally transmitted. Hepatitis B, if transmitted early by mother to child transmission, it leads to more than 90% of chronicity. Vaccination is the most effective preventive measure for hepatitis B, particularly because it can prevent the infection in early childhood. So no chronic infection, no cirrhosis, no cancer, decrease in death. Birth dose can play a very important role. If it is given along with 2 additional doses, 90% of mother to child transmission can be achieved. Antibody titer, if it's once more than 10, then it is adequate, the person is adequately protected against hepatitis B transmission. Other than this, safe blood, safe injections, safe sex, they're effective in preventing both hepatitis B and hepatitis C. And one more thing which I like to add, test and treat can be the best possible strategy for hepatitis C. So thank you so much for your patient listening. I'm happy to take any questions.
Yeah, thank you, Ajit. A very succinct presentation. We are very happy with it. And as decided in previous lecture, I think the question answer we will shift to the end. Srikant sir, is it okay?
Yes, yes, you can. I think it's better that we do it at the end.
Yeah. Srikant sir, you can invite the next speaker, please.
Okay. The next talk is on screening, vaccination strategy, health education for hepatitis B and C at a community level. I have pleasure in inviting Dr. Archana Ramalingam. She is a scientist. She is a scientist in ICMR, Miri, Chennai. She has done her MBBS in Pondicherry, MD Community Medicine again from Pondicherry. She is a recipient of Professor R.K. Carr Best Graduate Award in Gold Medal in Community Medicine in 2014. She has worked in multiple research projects in JIPMER, which is the Institute of Prime Importance, as well as in ILBS. Has been a resource person for several workshops on research methodology and basic epidemiology. He is a recipient of IAPSM Ford Foundation Epidemiology Grant and has been awarded oral paper presentation in several conferences, including IPHA and JRECON. Our area of interest include non-communicable diseases, non-alcoholic fatty liver disease, metabolic syndrome, viral hepatitis, community-based intervention, promotion, and medical education. She's published several articles at national and international journal of literature. With this brief introduction, let me have a pleasure in welcoming Dr. Archana Ramalingam for this important and the last talk of this seminar. Over to you, Archana. Please go ahead.
Thank you so much, sir, for that kind introduction. And good evening to all of you. And I think my presentation is the last presentation, and the speakers previous to me have already touched upon most of the important areas that I'm going to talk to you about. So without much ado, I'll just begin my presentation. So please give me a minute to just share my screen and is my screen visible?
Not yet.
No, it is not.
Yeah, just give me a minute.
Can't see these slides.
Hello.
Yeah, now we can see.
Yeah, okay. Thank you, sir. And good evening, everyone. I'll keep my presentation very brief. Most of what I intend to speak, I think the speakers before me have already covered. So I would be talking to you about screening for viral hepatitis B and C, vaccination, and the importance of health education and what could be the various strategies for health education. So when we talk about screening for viral hepatitis, the first and most important question that we need to answer is, whom do we screen for hepatitis B and C? Now, if you would have paid attention to what Dr. Ekta was mentioning, under the National Program for Viral Hepatitis Control and Prevention, anyone who walks into a testing facility should be offered testing services for hepatitis B and C. But of course, priority or preference is always given for individuals who are at high risk for acquiring these two conditions. So who are these individuals who are at high risk for acquiring hepatitis B and C? Dr. Ajit very nicely talked to you about transmission. And so I'm sure that all of you already are well aware of the high-risk groups. The most important high-risk groups are pregnant women, people who use injection drugs, of course, the healthcare fraternity, doctors, nurses, lab professionals, anyone who's involved in frontline and medical colleges as well as hospitals, people who undergo hemodialysis, individuals who have HIV or are at high risk for HIV, like that of individuals who are commercial sex workers, people who have men who have sex with men, injection drug use, and of course, there are certain other groups like people who are in close contact with patients who are positive for hepatitis B and C, or individuals who get tattoos from unsterile parlors. So these are the individuals who are at high risk for acquiring hepatitis B and C, and these individuals should definitely be offered screening services for B and C. Now, what are the tests that are commonly used for screening? The screening tests nowadays are widely available, and these are nothing but rapid CART tests, which are based on the lateral immunoassay principle. And for B virus, usually we test for the surface antigen. Now, I'm sure you've seen the picture of hepatitis B virus displayed by Dr. Ekta previously. And for C, of course, we test for antibodies to Hcb. So these rapid CART tests are really easy. They are single-use disposable assays and can be even done by healthcare providers in the most peripheral of institutions like that of a PHC or even a health and a wellness center. Generally, these rapid CART kits do not require any additional reagents, and usually you have all the reagents available in the kit. And once the sample is placed in the indicate area, within 15 to 30 minutes, you can usually read the CART test and see if there is a line across the test one as well as the control one and make your conclusions. These screening tests also, I would like to bring to your attention, have got very good sensitivity and specificity, and therefore they can be used definitely in the peripheral centers for screening. So to conclude about the screening, the individuals who are at high risk are definitely the priority group for screening. And we've got simple, easy, and very, very cheap rapid diagnostic kits available for screening of B and C. So therefore, all the peripheral institutions and even the health and wellness centers available in villages must adopt these screening as per the national program guidelines. When we move on to vaccination, of course, I'm going to speak only about hepatitis B vaccine. This is a vaccine which contains the viral protein for hepatitis B surface antigen. And initially, when it was during the initial days, this protein was obtained from patients who had chronic HBV infection. Of course, nowadays we use the recombinant protein. This is obtained from inserting the gene into the yeast or mammalian cells and then culturing the protein and using it for recombinant vaccines. Now, there are several types of hepatitis B vaccines, of course, and this could be a single antigen vaccine in the form of Engerix B. Commonly, most likely, many of you who would have taken it during your college days might have taken this vaccine. And of course, the government supply pentavalent vaccine is there for the children. And this, in addition to hepatitis B, offers protection against diphtheria, tetanus, pertussis, and Haemophilus influenzae B. Of course, if you go to a private pediatric practitioner, most likely they would be offering you an hexavalent vaccine, which also, in addition to all the ones that I mentioned in the pentavalent, offers protection for injectable polio. That is, it also has injectable polio vaccine. Of course, in the West, you also have twin rigs, and in India also you nowadays do get this. When we talk about stability and storage of these vaccines are very stable and they can be stored in an ice-line refrigerator at the PHC level. And one important thing that we need to remember is they are very sensitive to freezing and must never be frozen or kept in the refrigerator in the freezer compartment. When we talk about dosage, the dosage that is given for infants and newborns is usually 0.5 ml, whereas for adults it is 1 ml. And of course, people who have an immunocompromised state or the hemodialysis patients require a slightly higher dose in the form of 2 ml. Now, this is the most important take-home slide as far as vaccination is concerned. The schedule for hepatitis B vaccine for newborns and infants is something that all healthcare practitioners must remember. So Dr. Ajit, of course, mentioned the importance of birth dose. In addition to birth dose, the completion of 6, 10, and 14-week dose is also very important. When we look at adults, the schedule is 0, 1, and 6 months, of course. So the site of administration, just to touch upon, for the newborns and infants, usually we give it in the anterolateral aspect of the thigh, and for adults, we give deltoid. Usually gluteal muscles are avoided, giving injections there because of the risk of sciatic nerve injury. Now, if at all a person takes only 1 dose or 2 doses or 3 doses, what level of protection is offered by this hepatitis B vaccination is something that we must know. If an infant takes only 1 dose, the protection level is 16 to 40%, whereas second dose and third dose offer a high level of protection, 80 to 95% and 98 to 100%. Now, is it automatically, if you're vaccinated, does it mean that you're immunized against this infection? Of course, for individuals, especially healthcare workers, at least one-time testing of anti-HBs is very good, because there could be a certain proportion, like 5% of individuals who are non-responders to vaccines. So healthcare professionals can at least once in their lifetime test their anti-HBs titers. And if the titer level is more than 10, then definitely there is a vaccine response. And any immunocompetent individual who has at least once in their lifetime tested anti-HBs and found the values to be more than 10 need not consider a booster dose or need not think further about it. Because once you produce an adequate immune response, the immunity lasts for more than 30 years. And this is already found in studies. So in answer to one of the questions also, I've already responded. Anyone who's an immunocompetent individual who's already had an anti-HBs test done and the level is more than 10, then definitely he does not require any further booster doses. Now, common question that we often get is, what about missed vaccine doses? So if the vaccine schedule is missed after the first dose, then usually the second dose should be administered as soon as the person remembers or as soon as he comes in contact with the healthcare system. But care should be taken that for adults, at least, the interval between the second and third dose should be 8 weeks, and for children, at least minimum 4 weeks. Now, if suppose somebody has missed only the third dose, then of course, as soon as he comes into contact with the healthcare professionals, then the dose can be administered as soon as possible. Now, what about individuals where we have got an unreliable vaccination history? That means the individual does not remember whether he or she is vaccinated against hepatitis B. And sometimes the patients may not remember if they have completed their schedule of hepatitis B vaccination. In those cases, one must remember that, administering extra doses of single antigen hepatitis B vaccine is definitely not harmful. And whenever there is an unreliable vaccination history, or if somebody does not remember their vaccination history, you can go ahead and administer extra doses. It's not going to really harm the individual. Now, another question that we often get is whether an individual can take hepatitis B vaccines during pregnancy. Neither pregnancy nor lactation is a contraindication for this vaccine. It does not contain a live virus. Therefore, definitely pregnant women can take this vaccine. And even among pregnant women, who are the ones who should be given priority, or definitely who should be recommended if they are not already vaccinated, is individuals who are pregnant and who have more than one sexual partner, individuals who are pregnant and are getting evaluated or treated for an STD, a pregnant woman who is currently an injection drug user, or a pregnant woman with a HBsAg positive sexual partner or a spouse. So these are the individuals who, during their pregnancy, if they are not previously vaccinated, should definitely be considered for hepatitis B vaccine. Now, what are the common adverse events? Now, most of the adverse events that are associated with hepatitis B virus are mild and are commonly associated with any other vaccination, like pain, slight erythema in the region of the vaccination, and slight swelling. some of the individuals may experience a minor headache or might experience a rise in temperature, which will usually go off in 1 or 2 days. But the severe adverse event, which is also a contraindication, is the anaphylaxis event, which of course is very, very rare. Now, the studies have shown that if 1 million doses of vaccine are administered, only one individual might get anaphylactic reaction. So if an individual has got a severe allergic reaction to the vaccine, or if he has previously had an anaphylactic reaction, then that individual should not, that is one of the contraindications for vaccination. Of course, when we talk about birth dose, even children who are premature or who are born with low birth weight, or people with small for gestational age, and individuals who are born to mothers with HIV infection or who have jaundice at birth, these are not contraindications, and you can safely administer hepatitis B vaccine in these children. So also another question that we get is it like you can definitely administer with other childhood or adult vaccinations and there is no mutual interference. Moving on, why is this vaccination strategy important? This vaccination strategy, as Dr. Ajit has already mentioned, is crucial and it's crucial component of the interventions listed in the Global Health Sector Strategy for Elimination of Viral Hepatitis. It is one of the key strategies for elimination of viral hepatitis B. And the service target, of course, that globally we want to achieve is at least 3 doses of hepatitis B vaccine given to 90% of all children who are eligible. And of course, achieving a target of 90% coverage for the birth dose, which is crucial and vital in prevention of mother-to-child transmission of hepatitis B virus. Now, if you look at a country like India, most common route of course, acquiring hepatitis B also is mother-to-child. So vertical transmission needs to be stopped, and improving the birth dose coverage is most important for this. Now, what is the actual coverage of the 3 doses of hepatitis B vaccine in India? So we do have the NFHS surveys which inform us about this. The NFHS 4, which was done in 2015 to 16, showed that the coverage at that time was slightly more than 60%, whereas the latest NFHS, which is the NFHS 5, 2019 to 21, shows that the coverage is approximately around 84%. So we have definitely improved from 2015 to present, but of course we are not yet reached the Global Health Sector Strategy target of 90%. So still a small way to go when we talk about the 3 doses. But what about the birth dose? The birth dose is something where India needs to really work on. And the importance of birth dose, as already Dr. Ajit has mentioned this, if you look at this very important graph, you will understand that based on the age at infection, the potential for chronicity varies. So if you look at a person who has got infection at a very early age, let's say at birth, the chances of that person developing chronic infection is very high, sometimes even to the tune of 80 to 90%. Whereas if you see an older child or an adult who has acquired infection, the chances of chronic infection is only about 10 to 20%. So preventing early infections is very key to reducing the number of chronic infections. And of course, as already mentioned by the previous speakers, it is the chronic infections, especially chronic hepatitis B and C, which are associated with a lot of mortality when we talk about viral hepatitis. So since early infection is associated with a greater risk of chronic infection, it is more important to address this, and therefore prevention of mother-to-child transmissions is key as far as hepatitis B is concerned. So what is a timely birth dose? Just to again repeat, it is usually better to give the dose immediately after birth or as early as possible, but at least within the first 24 hours. And a birth dose followed by at least 2 doses, already studies have shown that effectively prevents mother-to-child transmission in more than 90% of the cases. So right from 2009, the WHO has been advocating for birth dose. However, even as of 2014 and even like latest in 2016, the birth dose coverage is not more than 40% on a global average. And in India also, the birth dose latest estimates we have is roughly about 45%. So one of the key areas where all healthcare professionals need to concentrate is to improve the birth dose coverage. So even though we have achieved an institutional delivery rate of about 75 to 78%, we still have not achieved a very good birth dose coverage of hepatitis B vaccination. So as healthcare providers, all of us need to advocate for improving the coverage of hepatitis B birth dose vaccine. Now, what about immunoglobulin? Of course, to an hepatitis B surface antigen positive mother, for the child, you need to, of course, give hepatitis B immunoglobulin, but there are certain challenges within the health system in terms of high cost of hepatitis B immunoglobulin, as well as the limited availability. But whenever you are giving, caution needs to be exercised, and you need to give it on the contralateral limb using a separate syringe. So to summarize about vaccination, it is one of the most efficacious strategies for prevention and elimination of viral hepatitis B, and it offers very good protection, especially when you take 3 doses, the protection is more than 95%. And any adult individual who has completed the schedule of hepatitis B vaccination and has done the anti-HBs test at least once in their lifetime with a titer of more than 10, he or she does not really need to think about booster dose. Booster doses are only indicated in individuals who are healthcare workers, as well as people who are like hemodialysis patients who have got a low antibody titer and who need who are repeatedly at risk and need protection. So when we talk about mother to child transmission, birth dose, as I said, is something where we really need more interventions, and birth dose followed by 2 doses of vaccination has got very good efficacy in preventing mother to child transmission, which is where all our public health efforts need to be placed. Just to conclude, to talk about health education, several health education strategies are there which are very efficacious for conveying messages and improving the awareness of the population. A lot of these strategies like posters, conducting some competitions, having brand ambassadors, using the social media platforms, running campaigns specific to diseases, as well as having conclaves and bringing in different stakeholders have all been tried for various diseases, including hepatitis B. And here in this context, I would really like to congratulate and appreciate ILBS's efforts towards spreading awareness about this very important disease of hepatitis B and C. So ILBS, through the empathy campaign, has developed several posters which have got very good communication messages, whether it's about hepatitis C treatment, or whether it is about mother to child transmission, or whether it is about birth dose vaccination, or even general awareness about hepatitis. They have done all this through a lot of posters, and they have conducted several innovative competitions in order to improve the awareness. One such very interesting thing is the cartoon competition that they conducted, wherein people from over 40 countries had participated, and it was really, it gave a lot of insights on how artists can visually represent and spread awareness about viral hepatitis. Another interesting initiative, which I was also lucky to be a part of, is the Happy School initiative, where they try to involve the stakeholders at the schools, the principals, the teachers, and even some students. And all the Delhi school principals and teachers were, part of the scheme, and then people were given awareness about viral hepatitis. And of course, the empathy campaign does have Mary Com as their brand ambassador, and she frequently tweets about viral hepatitis and also has been part of several of their video messages. Of course, the faculty videos from ILBS are an important source for awareness for the general public as well as for the medical professionals about viral hepatitis. We've got key speakers like Dr. Sareen and Dr. Ekta who continue to give these lectures in several fora. And of course, Empathy Campaign has run several iPledge campaigns and is involved partners from both corporate as well as from media, and has spread awareness, and has also included certain key parliamentarians and policymakers as part of their campaigns. So they do have a very good social media presence as well in Twitter, Facebook, as well as on YouTube. So I think we need to really congratulate ILBS for taking the initiative and for spreading awareness about this very important disease. Thank you, everybody. And that is all I have for today. Over to you, sir.
Thank you, Archana. It was a wonderful overview of the entire subject. and you covered it so well, and the importance of vaccination, especially the 3-dose vaccination, which is very important. Safety in pregnancy is emphasized, and anti-HBs titer are protective. There is no need of booster. I have a couple of questions for you. Uh, why initially we were promoting the birth vaccination and then another 2 doses of vaccination? But now it is 6, 10, 14. Why it is so? That's question number one. And why in the infants there is only 4 weeks gap between the second and the third dose, while in adults it is said that you should have a 2 months gap. Any light on that?
So I think it is based on the vaccine efficacy studies, sir. Though I'm not I cannot currently pinpoint you to one study proper, but I can refer you to the CDC guidelines and the mortality morbidity weekly review meetings, mortality morbidity weekly updates, which the CDC gives, where the guidelines is currently for children 6, 10, and 14 weeks. But you are very right. There are countries where the vaccine schedule for even children is 0, 1, and 6 months. So, of course.
I read in the slide, it is birth 6 weeks, 10 weeks, and 14 weeks.
Yes, sir. That is the current vaccination schedule that India follows. So in India, under the universal immunization program for children, we use the birth dose followed by 6, 10, and 14 weeks. That is the schedule that we follow. But of course, I agree with sir that there are some countries where even for children, the dose schedule is 0, 1, and 6 months. So that could also be followed. And a minimum period of 4 to 8 weeks is what I think several studies do recommend between the vaccine doses. So though for adults, we generally recommend at least 8 weeks. For children, a 4 weeks dose is what is recommended. These are based on the clinical trials and vaccine efficacy studies, and of course, the acceptable schedule as per the different immunization programs in different countries.
What is your advice for those who don't get antibodies, don't get anti-HBs titer? That forms a 5% of the population.
Sir, yes, usually for non-responders, sir, and I think Dr. Ekta can also supplement me. A general recommendation as per the CDC is to repeat the 3-dose schedule again and try to see that if they develop an antibody response. But if you see that that still does not develop an antibody response, then they need to be checked. They need to be checked for various other immunocompromised conditions and really see why they are not able to produce an antibody response.
Do you believe in giving double dose to these people? Because what I read many years back is if they are not getting the antibody response, they should be offered double the dose of vaccine. That's a 2 ml.
So for immunocompromised individuals, the general recommendation is doubling the dose, sir. So even to begin with, if you do know that the individual is an immunocompromised individual, or if the individual has got repeated risk like that of a hemodialysis patient, then the initial recommendation itself is to when you first give the first 3 doses itself is to give 2 ml. So if that still does not produce a vaccine response, as in the non-responders, then one of the recommendations that CDC gives is to repeat the schedule again and see if they develop a response. And if they do not, then definitely they need to be evaluated further as to why they are not producing an antibody response.
Abhiram, you have some questions?
Yeah, we are going ahead with question answer, or the pledge administration of pledge is next in the agendas.
Good evening, everyone. Please allow me to give you a brief about iPledge. iPledge is one of the key activities under Empathy Campaign project, which aims at motivating people towards maintaining liver health and help in contribution towards liver health. Awareness regarding prevention and control of hepatitis B and C. May I request everyone to please switch on your camera and raise your right hand so that we can proceed with the oath. And I would request all of you to please repeat after me. I pledge that I will try to keep my liver healthy.
I pledge that I will
I
try to
pledge
keep my
that I will
liver
try to
healthy.
keep my liver healthy.
Try to keep my liver healthy.
I pledge that I will get myself and my family tested and vaccinated.
I
I
pledge
pledge
that I
that
will
I will
get
get myself and my
my
family
family
tested
tested
and
and
vaccinated.
vaccinated.
My family tested and vaccinated.
I pledge that I will generate dialogue with my colleagues on hepatitis.
I pledge that I will generate dialogue with my
I will
colleagues on
generate dialogue with
hepatitis.
my colleagues on hepatitis.
I pledge that I will teach 10 people about hepatitis.
I pledge that I will teach 10 people about hepatitis.
I pledge that I will not discriminate people living with hepatitis.
I
I pledge that I will not discriminate people living with hepatitis.
I pledge that I will contribute in empowering people against hepatitis.
I pledge that I will contribute in empowering people against hepatitis.
Thank you. Over to you, Dr. Namta.
Thank you so much. And thank you for the moderators for really skillfully and effectively moderating through the sessions. Those were really very informative, to say the least, and the insights that the speakers gave for the topics, the choicest topics that were put together for this session were absolutely very enlightening. And I hope that the participants must have gained valuable insight regarding those topics. Thank you so much for the moderators for chairing the session. The forum is now open for question and answers, and I would request the panelists to kindly answer the questions. The participants can drop their questions in the chat box.
Dr.
We
Ajit,
do have
I
a
would
question.
ask some questions. Dr. Ajit is here?
Yes, I'm here.
Yeah. As the mother-to-child transmission for hepatitis B is the most important way of transmission, what is the role of giving antivirals to mother in third trimester?
Please repeat it. I missed it.
Since mother-to-child transmission is the most important route of transmission, what is the role for giving antivirals to mother for hepatitis B?
Role of antivirals in mother.
Mother, pregnant woman, how do we prevent transmission to the child? Question is that.
Right, sir. So in third trimester, we can give, if the hepatitis B virus load is very high, then we can give antiviral treatment in third trimester to decrease the transmission. Otherwise, most of the times, birth dose and immunoglobulins, they can take care of mother to child transmission.
Yeah. So the antiviral in third trimester, does it add to the advantage?
Yes, it adds to the advantage if hepatitis B virus DNA is at higher level.
Okay.
What do you mean by higher level? What is the cutoff?
Different guidelines, they talks about different level. Some says more than 2,000 is high, and some says more than 20,000 is high. So in our program, it's more than 2,000.
So even if 2,000, more than 2,000, you suggest that they should be put on.
Yes, sir. Mostly I mean, in the program, it is mainly decided by gastroenterologist. They'll decide whether to give according to, because hepatitis B treatment is a bit complicated one to decide upon treatment eligibility. It's based on ALT level also, it's based upon DNA level also, it's based upon liver fibrosis also. So that's why in program, to keep it simple, we have mentioned that whenever there is any complication, refer it to model treatment center where there is a gastroenterologist or a trained physician to manage these cases.
At some places, hepatitis B screening camps are being conducted. So if you find some person hepatitis B positive, it will be giving a lifelong fear to him that he will be remaining positive for lifelong. So do you recommend to have such camps for hepatitis B testing?
Hepatitis B screening camps, they are very important to pick up those who are hepatitis B positive, because I know that it's a lifelong care, and it is something where treatment is also not given readily to everybody. So if they know that they are hepatitis B positive, if they get themselves tested every year for ALT, DNA, and fibrosis, that I know that there is a cost involved in that, but at least they'll be knowing that they can when they need treatment. So we can at least prevent cirrhosis and liver cancer in these cases, and they'll not.
But it will be giving them lifelong fear for suffering.
That's, I mean, I mean, at least they are knowing that they are exposed to a danger of cirrhosis and liver cancer, so that they can be in touch with their physicians and can keep on regularly monitored. So I think that's very useful. That's very important to decrease the mortality with hepatitis B.
Ajit,
yes, sir.
I have two questions for you.
Yes, sir.
See, in spite of vaccination program in 2007, we are now 15 years down the lane, and still we feel that hepatitis B is not that much controlled. How do you explain this?
Sir, you have seen in the slides of Dr. Manya that prevalence is decreasing. So if we say prevalence is decreasing, that may be because of vaccination, that we are not getting new infections. So in one of the talk of Dr. Sareen, he also mentioned that we can eliminate hepatitis B by 2080 if we can have a coverage of 90 or 100% for vaccines. So this is something which will give fruits later on after many years. So I think 15 years is not that good enough time period to comment on decrease in burden of hepatitis B, hepatitis C, hepatitis B, and mainly the mortality part, sir.
Do you foresee eradication of hepatitis B like polio?
Looking very difficult and very far, even for hepatitis C also, though we have cure, because 95% they are asymptomatic. It's not easy to find them. It's not easy to get all tested and treated. So very difficult. Elimination is, I think, decreasing 90% of incidence, 65% mortality is good enough to achieve.
How about vector transmission, mosquito, and what is your view on vector transmission?
So I think that's very low or less percentage of contribution to mode of transmission. So as a public health expert, I'll say I'll target the bigger fish than the smaller fish.
Any more questions in the Dropbox? I think they should be addressed first.
There are many questions in the chat box. Yes, sir.
You can take the relevant questions to be asked to the speakers.
Okay, sir. So there is one question that what to do if second dose of hepatitis B vaccine is missed by a patient?
I think that is already answered, madam.
That is already answered. Yes. Then one question is regarding if we want to rule out hepatitis B negative, what are the tests to be done? I think that is also answered.
Most of the questions in question answer session, they are answered.
Yes, sir.
Normally, you should do hepatitis B surface antigen and antibodies to core as a screening test, because doing HBV DNA in every patient is costly. So for screening, I would suggest that HBsAg and antibodies to core antigen should be done. If the antibodies to core antigen are positive, then probably I think they should undergo HBV DNA PCR testing.
Right. So mainly we go for hepatitis B surface antigen only. But yes, if it comes positive, then you can go for antibody core also to see is it IgM or it is IgG to differentiate between acute and chronic. And then you can go for DNA also, ALT and other things to decide upon for treatment. But for family screening, yes, I agree with Dr. Shrikant, sir. If we are going for family screening in high risk groups, antibody for hepatitis core and antigen will also help, because sometimes there are some cases of occult hepatitis B also, where hepatitis B surface antigen is negative but core antibody is positive, and then you go for and you find DNA.
The anti-HBC IgM, normally the clinical scenario is such that the patient has acute hepatitis. Then only you go ahead with doing the IgM antibody.
Right,
but the majority of the chronic hepatitis are mainly incident detected hepatitis, where you won't require if the HbSAg is positive.
Right, sir. I agree with you.
Sir, in that regard, you said family vaccination. So one question regarding that should spouses of healthcare worker who are non-medico, whether they should take the help of B vaccination or hepatitis B vaccination or not?
Can you repeat the question, Sushma?
Sir, the spouses of healthcare worker who are non-medical, so they should also take the hepatitis B vaccination or not?
I responded it in the question answer session, mentioning that yes, she can also be vaccinated.
No,
If
I
they
think
are-
so.
they-
Can I get in?
Yes, sir. Please, Umesh Kapil, sir.
Yeah. It's a very simple, straightforward, madam. Each and every individual in the country should get HBV vaccination. So there is no question of whether the health worker's wife is positive, negative. Everybody should get it.
Yeah,
Right. So we have a universal hepatitis B vaccination, and we are immunizing almost 90% of the infants. Right. Even the newborn immunization is very high, up to 60 to 70%. Right at the 0 day. So we are making excellent progress. But remember this: if you want to eliminate the hepatitis B from the country, it will be 2080, because by that time this new pool of newborns would become adult, right? And this is a sustained efforts which has to go in to undertake this. Thank you very much. Over to you, sir.
You should rule out HbA positive status before vaccination.
Yes, sir, we can do that. But the issue is that to get the HbS AG titers done.
Not titer, only positive or negative.
That can be done.
No point in vaccinating a positive person.
Yeah, that is fine, sir. I totally agree with you.
So there are two more questions I want to ask, which is in the chat box.
Please.
How to monitor patients of CKD on regular dialysis who have taken anti-HCV treatment previously, and if they came positive again, then how to treat such patients?
Ma'am, it's a very specific question. And this is one-to-one clinical practice question. A nephrologist would be able to answer it. We are having this webinar with the focus of public health intervention. We are dealing with 140 crore people. So we'll not be able to give you a correct and a valid advice, because this is a pure clinical question. But I can assure you, just send me an email. I'll get it, my nephrology consultant, and get you the response definitely. Thank you, ma'am.
Yes, sir. Thank you, sir. Sir, one more question regarding the hemodialysis only, because it has been asked by one of the participants that hepatitis C is rampant in hemodialysis unit in government hospitals. So they want some directions or protocols for the prevention. What precaution or prevention they should do? This is the question from one of the participants.
Ma'am, there are specific guidelines which have been there in place for hepatitis C, B. All the blood transfusion are being undertaken. The screening has to be done before any patient is being given any blood. So that's a part of the all blood banks have been registered with the hepatitis national viral hepatitis control program. So this has been done, ma'am. But yes, if there are any specific guidelines are required, then definitely I'll share that with you, the manual of the Government of India under National Viral Hepatitis Control Program soon after the meeting. And then all these things have been clarified. All possible issues have been clarified in these clinical management guidelines. Over to you, ma'am.
Okay, thank you, sir. Thank you, sir. All the other questions have been already answered during their speech. So there are no more questions in the chat box.
Ma'am, I personally, Professor Umesh Kapil, with ILBS, would like to extend my most gratefulness to IMA in Nagpur. We have such a good attendance, good active participation. Usually what happens, and when we do these type of webinars, people just log on and then they start moving around. But I'm sure that Marathi Manush is always a very conscientious person.
Yes, sir. Thank you so much.
no. I have a lot of respect for them, and we are most grateful to you, sir. Thank you very much, ma'am. Thanks a lot, and we look
On
forward
behalf
to
of
our.
me and Abhiram, we are grateful to asking her to join this important webinar, and we thank ILBS and IIM Nagpur for giving us this opportunity to do that. Thank you so much.
Sir, we are just for
Thank
your
you, Kapil sir,
information.
Ajit, and everyone. Thank you.
Sir, we are doing 2 to 3 liver transplant every week.
Very
And
good.
if with just a question of about 15 to 18 lakh rupees. So if there's a poor person, please do refer to us, not because of their self-interest, but for the benefit of the patient. Please
Sure.
send them. And if he is a card holder, okay, BPL card holder, he'll get a free treatment from this hospital.
Okay.
Right, sir?
Thank you.
Thank you very much, sir.
Nice
Namaskar,
initiative,
sir.
Thank you.
Jai
Thank
Hind.
you. Thank you.
Jai Hind.
Thank
With
you,
your permission,
Sushma.
can we close?
Yeah, I think we should close.
Can we fill the questionnaire after the meeting?
Sir, that's an online thing. So as
Okay,
soon as
okay,
we
okay.
get the questionnaire, we'll start issuing the e-certificate to all, sir.
Yeah. The post
Thank you.
webinar link is to be filled. That
Yes, sir. Thank you. It's a 5 questions only, sir.
okay. Thank you.
Thank you, sir. Thanks
Thank
a
you.
lot, sir.
Thank you so much to the panelists and respected Kapil sir as well for dropping in and sharing the insights and also answering the questions. I'm pretty sure that most of the questions that were posted in the chat box have been answered because of the questions that were taken up were quite broad-based and touched upon few of the important aspects that could have posed a certain query. So thank you so much for very efficiently and very effectively answering those questions. May I now kindly invite Dr. Sushma Thackeray to please give the concluding remarks and end the webinar. Thank you.
Okay, thank you, Dr. Namrata. So it's been pleasure being with all of you today. So thank you very much for that. And I must take this opportunity to congratulate today's speaker for their excellent presentation. So congratulations to all the speakers, Dr. Kavita Gupta, Dr. Manya, Dr. Ajit, and Dr. Archana. They have covered the topic very well. They have explained everything in a very simple way. And then second question and answer session was also very good. Important questions were asked by the participants and it was answered very satisfactorily by all the speakers. And I think with this speeches, the recent advances in prevention and control of hepatitis B and C, it will definitely create the awareness among the people. And because first we need to create the awareness among our doctor fraternity, then our doctors can create the awareness among the people. So with this webinar will be very effective for this. And again, I'm thankful for giving me the chance to conclude the session. Thank you very much. And over to you, Namrata.
Thank you so much, Dr. Thackeray. Can I please now invite Dr. Sachin Gathe, Honorable Secretary, IMA Nagpur, to kindly give the vote of thanks. Over to you, Dr. Sachin.
So at the end, on behalf of IMA Nagpur, I would like to thank all the speakers. I will not take the name, everyone. So I'm the chairperson. Thank you for attending and taking part in this webinar on this recent advances in prevention and control of hepatitis B and C. I am very grateful to Institute of Liver and Biliary Sciences, New Delhi, who have participated and requested us to conduct this webinar. And we have got a very huge response. More than 250 delegates were joined in this webinar. I would also like to thank our digital partner, Digishil, Dipen, Piyush, Vaishali, also all the audience. Thank you very much, and you can log out.
And thank you to today's MOC, Dr. Namrata. Thank you so much. You have conducted the session very nicely. Thank you so much.
You're very kind, ma'am. Thank you. Appreciate it. Thank you so much. Have a good rest of the evening.
Thank you.
Thank you, everyone. Bye.
Bye, sir.